The big fresh carrot.
And a whole lot of cheese.
And the mirror from your van is halfway down the street.
You can say that. Wait, what?
Well, I said someone just clipped the side of your mirror right off the delivery van.
When owning a small business gets real, Progressive gets you right back to living the dream.
Now, where were we?
Why, you were fixing to peel me.
which has at this point given an average of about 5 years of progression-free survival, and which is followed by multiple relapses and therapies for each of these relapses in multiple myeloma. So one critical change that has happened, I would say, over the past 5 years is the whole concept of early intervention in multiple myeloma that is now backed with data from clinical trials. As you all know, active multiple myeloma is just one end of a spectrum of monoclonal gammopathies that starts with monoclonal gammopathy of undetermined significance, a condition that can be present in as many as 10% of people at 70 years of age. A small proportion of them, roughly about 20% during the lifetime, will progress on to active myeloma, some of them going through a transitional phase called smoldering multiple myeloma. One of the biggest concerns about early intervention in this precursor phase has been that we might end up treating a lot of patients unnecessarily who might otherwise have never developed multiple myeloma. So it was very critical that we identify these patients who are at the highest risk of progression to active myeloma. So one of the things that has been realized early on is that about 50% of these patients with smoldering myeloma will go on to develop active myeloma during the 5 years. But it's important to identify who are these. More recently, the International Myeloma Working Group developed a staging approach or risk stratification approach in smoldering myeloma that incorporates the free light chain ratio, M protein level, bone marrow plasma cell percentage, and FISH abnormality. And now we can identify 4 distinct groups with very different risks in terms of progressing to active myeloma. Now, this clearly set the stage for, again, a targeted approach for those patients at the highest risk. The CURIDEX trial, which is the Spanish trial, randomizing patients with high-risk smoldering myeloma to treatment with lenalidomide and dexamethasone versus observation, had previously shown that there is improved PFS and improved overall survival for patients with high-risk smoldering myeloma. More recently, there has been the ECOG trial, which looked at, again, high-risk smoldering myeloma, randomizing them to lenalidomide alone versus observation, and demonstrated that there is improved progression-free survival for those patients considered to be high risk by the Mayo or the IMWG 20-20 risk stratification criteria. In contrast, patients with intermediate risk and low risk do not get any benefit, highlighting the importance of identifying the right patients for early intervention. So this field is rapidly evolving. There are phase 3 trials ongoing looking at more intense therapy than just lenalidomide for these patients with high-risk smoldering myeloma, with an eye on cure potentially for this disease. Now, just as in smoldering myeloma, we know there is significant heterogeneity in the outcomes of patients with active multiple myeloma, and in the importance of risk stratification cannot be highlighted or stressed upon more. The classical definition of active myeloma has traditionally included the hypercalcemia, renal insufficiency, anemia, and bone disease. And with the more recent, again, revision of the diagnostic criteria, now we have bone marrow plasma cell percentage, a PET MRI lesions, as well as an FLC ratio that expanded the definition of active myeloma to include those patients with smoldering myeloma, in whom the risk of progression is more than 80% at 2 years. Now, one thing to keep in mind when you have these patients with high free light chain ratio, it is also important to note that this applies only to patients who also excrete these light chains in the urine. There is a small subgroup of patients, as indicated in this red line, who may have high free light chain ratio, but does not excrete any free light chain in the urine. And these patients actually don't seem to have the same degree of risk. Now, many of the groups have shown that there are a variety of different prognostic factors that identify those patients with active myeloma who are not destined to do very well. And these primarily include genetic abnormalities like high-risk IGH translocations involving chromosome 14, 1q gain or amplification, abnormalities of chromosome 17, ISS stage 3, and elevated LDH. All these appear to provide a comparable increase in risk. And in fact, you can add them on, and with each added or additional factor, your risk of a poor outcome goes up. And in fact, if you have 2 or more of these abnormalities, your median overall survival is significantly lower than those patients without these abnormalities. Now, with that in the background, let's just talk about the therapeutic approach and how the landscape has changed over the past few years. So clearly, the myeloma therapies have evolved considerably over the past 2 decades. At the beginning of this century, we had alkylating agents, anthracyclines, and steroids for treating these patients. Since then, we have at least 2 dozen different therapies that are either been approved or going through therapies. Obviously, the novel agents, including the immunomodulatory drugs and the proteasome inhibitors, dominated the first decade. The last few years have been again dominated by the immune therapies, particularly the monoclonal antibodies, and more recently, the ADCs and the CAR-Ts and the bispecifics. And clearly, there are other therapies more targeted, including the HDAC inhibitors, the nuclear transport protein inhibitors, and the BCL2 inhibitors that are going through clinical trials or have been approved. So the challenge, I think, for us who takes care of patients with myeloma is how do we integrate all these new therapies in the treatment of multiple myeloma, again, knowing that we have to kind of go back to this set of drugs multiple times during the course of the patient's disease and still allow these patients to have the best outcome with the least toxicity possible. Now, I think one of the biggest changes have been in the arena of newly diagnosed myeloma, where 10 years ago, we started everybody on bortezomib, lenalidomide, dexamethasone based on the phase 3 data from the SWOG trial as the optimal initial treatment of patients going to an autologous stem cell transplant. And in patients who are not eligible for an autologous stem cell transplant, reduced dose BRD or BRD light had become the standard of care where feasible. Now, over the past few years, there have been a lot of interest in trying to improve upon this induction therapy, initially by replacing the bortezomib with carfilzomib. That did not lead to a significant improvement, as was shown in the Endurance trial, but more recently with the addition of monoclonal antibody into the upfront therapy. So this is the Griffin trial that looked at adding daratumumab and anti-CD38 monoclonal antibody to the VRD combination. Again, patients receiving this 4-drug or 3-drug induction followed by a transplant, followed by 2 cycles of the same consolidation, and then maintenance with 1 or 2 drugs. Now, the Griffin trial clearly showed that as you added the daratumumab to VRD, it not only improved the overall response rate, but more importantly, improved the depth of response, both in terms of the complete response and also in terms of MRD negativity. And this has translated to improved progression-free survival with the most recent data cut from the last ASH, even though we still haven't seen a significant difference in or any difference at all in the overall survival between the 4 versus 3 drugs. So clearly there are a lot of questions that need to be asked, that needs to be answered in terms of who are most likely to benefit from a 4-drug combination compared to a 3-drug combination. As we know that increasing numbers of drugs in the combination can also lead to increased toxicity. But it also brings up an important question about the duration of therapy. The current paradigm of therapy for multiple myeloma in the newly diagnosed setting particularly is one where we continue therapy until disease progression. Now, the MASTER trial is a trial that looked at the combination of daratumumab with KRD to see if this 4-drug combination approaches can allow more patients to get to be MRD negative and whether we can discontinue therapy based on the MRD negativity. So these are patients who were started on therapy with the 4-drug regimen, went to transplant, got consolidation with the same, and then had option of an additional 4 cycles of the same consolidation followed by len maintenance. But patients stopped therapy as soon as they achieved MRD negativity on 2 consecutive testing. Now, with this approach, clearly a significant proportion of patients were able to get into deep response, including MRD negativity in 50%. And when you look at the outcomes, you can see that even with the stopping therapy, you can see that patients with no high-risk abnormalities or one high-risk abnormalities can continue to remain in remission without continued therapy, while the patients with multiple high-risk abnormalities tend to relapse even while on therapy, highlighting the need for different approaches in these patients. Following the induction therapy, the typical approach has been to use a transplant-based consolidation. The questions continue to be raised whether we need transplant in the setting of these highly effective combinations. At least in the context of VRD induction therapy, the French group has shown that adding stem cell transplant as part of the initial therapy does improve PFS without a significant improvement in overall survival, as long as most of these patients can get transplant at the time of first relapse. So I think overall the message from both the IFM trial and the Forte trial that looked at KRD, transplant or KRD without transplant, suggests that this is a modality that still continues to play an important role. Now, whether it's going to have the same impact in somebody who is getting a 4-drug induction therapy remains to be seen. Post-transplant, the standard of care today is to use lenalidomide maintenance, and these patients often continue on len maintenance until disease progression. Now, the ideal duration of len maintenance remains unknown. There are phase 3 trials that are looking at different approaches. At the ASCO this year, we will be hearing about the updated results from the DFCI portion of the IFM trial looking at the role of transplant and continuous maintenance. Now, with the newer therapies coming online, there has been a lot of interest in trying to enhance the maintenance approaches. The Forte trial looked at adding carfilzomib to lenalidomide and demonstrated that there is clear improvement in PFS, not only for the standard risk, but an equivalent improvement in the high-risk patients as well as people with 2 or more high-risk genetic abnormalities. Now, whether everybody needs a 2-drug maintenance remains unknown, but at least in the context of high-risk disease, it seems to have made a significant impact. And in our own practice, we are starting to use those 4-drug combination induction therapy and 2-drug maintenance in patients with high-risk disease. Now, whether daratumumab plays a role in the maintenance remains a little bit unanswered, because the Cassiopeia trial showed a benefit for DARA maintenance versus no maintenance. However, this benefit seemed to have been primarily in people who, again, had not seen daratumumab as part of induction, or the people who did not see DARA in induction therapy appear to have same benefit as people who received daratumumab as part of induction therapy, suggesting not an added benefit in those people who are already seeing the antibody as part of induction therapy. There are phase 3 trials ongoing looking at DARA len maintenance versus len maintenance. That's a SWOG trial that is nearing completion of accrual at this point in time. Now, for the transplant ineligible patient population, the approach has been to use VRD light or using an RD induction therapy continued until disease progression. Now, the MAIA trial actually added daratumumab to Lendex and demonstrated that you can have a median PFS of almost 5 years that beats what we see with induction, transplant, and maintenance therapy in the transplant eligible patient population. And we know that the addition of daratumumab to Lendex also improves the overall survival significantly compared to the 2-drug combinations. So clearly, the incorporation of the new therapies, particularly the monoclonal antibodies, the newly diagnosed myeloma, has really changed the outcomes of patients with newly diagnosed disease. And hopefully this will continue to improve as we have some of these exciting immunotherapies that we are going to be talking about in the relapsed myeloma setting make its way into the upfront setting. So when you talk about the relapsed disease, again, we are talking about the early relapses where these patients often have not seen many of these newer therapies, and the late relapses where patients have become refractory to many of those newer novel agents and monoclonal antibodies that we just talked about. But when you think about changing therapy or deciding on treatments for patients with relapsed disease, especially in this crowded environment, there are certain principles that you need to keep in mind. One of them is, even though we have all these risk stratification systems, the duration of initial response often defines biology. We know that patients who don't get a prolonged response on their initial therapy tend to do very poorly with subsequent therapies, irrespective of the underlying genetic abnormalities. The second important question or fact that we have learned over the past decade is the importance of using combinations of drugs with different mechanisms of action. Trial after trial, the relapse setting have shown that triplets will do much better compared to two or a doublet. And it's also important that we incorporate at least one drug from a non-refractory class when we start thinking about a new therapy for patients with relapsed disease. We have to take into account the performance status, the age, comorbidities, etc., as well as the prior toxicities that these patients might have had. So again, without going into too much of detail, I think the overall approach for relapsed disease is to use triplets, use drugs that they have not seen before, and use drugs based on whether they are refractory to those drugs that we use in the upfront setting, particularly drugs like lenalidomide that are used in maintenance. And when they relapse, we can switch these treatments around so that we can actually give them combinations of drugs that they have not seen before. The problem really comes up and where we really need innovative approaches are patients when they become refractory to the immunomodulatory drugs, the proteasome inhibitors, and the monoclonal antibodies. Many people have shown that the survival in patients who have become triple class refractory is rather poor, as shown in these figures, particularly the ones on the right. So what are the options for those patients? We have some approved drugs, the selinexor, which is an XPO1 inhibitor. We have belantamab, the CAR-T, two CAR-Ts approved right now. There are also HDAC inhibitors and newer alkylators, but their role remains unclear at this point. There are clinical trials that are ongoing looking at T-cell engagers, cell modes, as well as BCL2 inhibitors. Now, selinexor is a nuclear transport protein inhibitor that in combination with bortezomib was shown to be much more effective than bortezomib alone in the Boston trial, and subsequent trials of selinexor with carfilzomib, pomalidomide, or daratumumab have again shown significant efficacy in these patients who have already become refractory to these standard of line therapies. And I think this is an oral therapy that certainly gives an additional option for these patients, but has significant toxicity that needs to be managed proactively. Now, the belantamab mafodotin is a antibody drug conjugate that targets BCMA, or the B cell maturation antigen that is commonly present on myeloma cells. The DREAM2 trial demonstrated the activity of single agent belantamab, which is about 30% in patients with a median of 4 to 5 prior lines of therapy, and the responses appear to be comparable across all the different subgroups studied. In fact, the median PFS for this was roughly about 3 months, but when you look at the patients who actually did get a response, the response did last for nearly 9 to 12 months. So there are two valuable takeaways from belantamab. It is an effective drug. When it works, the durability can be good, but it is also associated with significant eye toxicity that needs to be managed proactively. Now, clearly, some of the immunotherapies have been the most exciting advances in myeloma. Idacil or idacaptogene dipilicil was approved a little over a year ago now. This is a BCMA targeting CAR T cell. You're going to hear a lot about CAR T cell in these two sessions. I won't go into all the details, but again, want to highlight that patients with a median of 6 prior lines of therapy, majority of them triple class refractory, being able to get a 81% response rate is outstanding in myeloma. And these responses are often very deep, and the durability of response, we have seen the PFS with the Idacil is roughly about a year. Now, more recently, we have cilta-cel that was approved, again, a BCMA targeted CAR-T, but with the more avid binding of the antigen. The phase 1b trial, the CARTITUDE-1 trial, clearly demonstrated that you can get a response in the majority of these patients. And in fact, when you look at the PFS for the cilta-cel, it is close to 2 years, again, suggesting durable response in this heavily pretreated patient population. Clearly, these are drugs that are moving along to the earlier lines of therapy in the ongoing clinical trials. Finally, the bispecific T-cell engagers, clearly this is another group of drugs that has shown considerable efficacy, Simple, elegant design. This is an antibody that has specificity for a plasma cell antigen, BCMA here, and also for CD3 that brings the T cells closer to the tumor cells. The teclistamab is a BCMA targeted bispecific that we hope will be in the clinic later this year. And in the initial phase 1-2 study, again demonstrating a response of almost 62% overall response and a complete response of almost 30%. Some of these patients are able to get a MRD negative even in this heavily pretreated patient population. And in terms of toxicity, the teclistamab is very well tolerated, as are all the bispecifics. Majority of the patients do get cytokine release syndrome, mostly grade 1 or 2, easily managed. There is an increased risk of infection, partly related to the hypogammaglobulinemia, and this certainly needs to be proactively managed. There are other bispecifics on the way, like talquetamab, which is a GPRC5D targeted bispecific. Again, very similar to teclistamab in terms of its efficacy. About 60 to 70% of patients respond to this therapy. And in terms of toxicity, again, very similar profile with about 60 to 70% patients getting cytokine release syndrome. The third target is also being explored, which is FcRH5 in the form of cevostamab. And this is also a bispecific that appears to have activity very comparable to other bispecifics. So overall, when you look at the entire bispecific field, 3 different targets, response rates between 60 to 70%, cytokine release syndrome about 60 to 70%, and the responses are appearing to be durable for these patients. The venetoclax is a BCL2 inhibitor that is obviously been around for a while for treatment of CLL. And more recently, there's data from the Bellini trial and several other phase 2 trials that demonstrates the activity of venetoclax, particularly in patients with 11-14 translocation. So when you look at the Bellini trial that randomized patients to venetoclax, bortezomib dex versus bortezomib dex, you can see that the overall benefit was significant with a significant improvement in the PFS of about 22 months versus 11 months. But when you look at the subgroup of patients with 11-14 or BCL2, you can see that it's significantly active. And in fact, when you look just at the 11-14, you have a hazard ratio of almost 0.12, and which is also, we can see, is effective in BCL2 high patients. And these are patients who tend to be high BCL2 expressor based on PCR or gene expression. So clearly, that is a drug that is continuing to move forward in clinical trials. Finally, we have iberdomide, which is a CELMoD, a modified IMiD, which is again targeting the Ikaros and Aiolos through targeting the cereblon and leading to myeloma cell death. And recently, we have data from these clinical trials demonstrating that iberdomide can be quite effective even in patients who have been previously exposed to IMiDs and more recently also exposed to the BCMA targeted agents. So clearly we have small molecules that are going through clinical trials. We have immune therapies and also increasing data telling us how best to use these agents in that paradigm of continued therapy for myeloma. So I think we are at a stage where we can effectively use these drug combinations to get deep responses. And these 4 drug regimens are increasingly becoming part of the initial therapy, particularly for the high-risk disease. The Dara-Lentex combination, as in the Maya trial, has shown outstanding activity for the transplant-ineligible patients and should be considered the current standard, and we will continue to improve upon this. Maintenance therapy does add to the post-transplant progression-free survival, and the ongoing trials will tell us whether 1 or 2 drugs are appropriate for maintenance and how long do we need to continue maintenance. As we saw with the MASTER trial and others, the high-risk myeloma remains a significant challenge, but hopefully with the increasing incorporation of immunotherapies in the upfront setting and high rates of MRD negativity, this will become less and less of a challenge. I think the immunotherapy is going to be a key component of myeloma therapy going forward, and we will be seeing the incorporation of bispecifics upfront in combinations and CAR-T potentially replacing transplant in the earlier lines of therapy for at least a subgroup of patients. With that, I will stop and thank you for your attention.
That was fantastic, as expected, as always. Few questions. I can get and I want to report. One of them and ask you. One of them is that on the stratification of patient, obviously p53 is a factor across all cancers, including in myeloma. There's other abnormalities, but is the NGS bringing additional stratification in these patients? That some, in lymphoma, you see many more mutations of p53 that you don't see on a routine, and IHC is not a great test. So can you comment on the NGS?
Yeah, no, I think that's a great question. I think the future, we already know from the NGS studies that have been done, that's roughly about a dozen mutations that are commonly seen in the relapsed myeloma setting. And with increasing prevalence as we go through multiple relapses, about half of the patients have NRAS or KRAS mutation, and there have been studies, including the one from Hackensack, showing that if you can use MEK inhibitors in some of these patients and can get responses, the challenge has been maintaining these responses for longer periods of time. And we also know from a prognostic standpoint, mutations involving the TP53 gene, as well as the DNA repair pathways, can have significant prognostic effect in patients with myeloma. So I think both from a prognostic standpoint and also from deciding the therapies, these are going to have an important role. The trials like MyDrug that's ongoing, that's looking at the NGS as part of the initial screening and then assigning specific treatments based on the underlying mutations, probably going to be an important approach in the future.
You guys have done an amazing job in myeloma, adding drugs in lymphoma. We tried with a caveat that this was just cytotoxic really at the time, but we all know the story of the R-CHOP and then the complex regimen that happened to 17 drugs, and it turns out it was not different. You think that as we go from triplet, quadruplet, and quintuplet in myeloma, are we going to see always a superiority, or this is just an impression for now?
Yeah, Dr. That's a very, very important question. I think I'm glad you brought it up because, as we keep adding drugs with different mechanisms of action and hopefully non-overlapping toxicities, we can improve upon the depth of response. But I think there's going to be a deflection point where the incremental benefit is not going to be sufficient to balance the risk associated with these overlapping toxicities. So I think the best example is the DRVD regimen. We know the MRD negativity rate is really higher with the quadruplet. We know the PFS is better. We're still waiting to see if the overall survival is going to be better, which may not be, because eventually in a disease like myeloma, where we use multiple therapies in sequential fashion, there is a point where you might get more benefit from trying to use it in sequence rather than adding one on top of each other. So I suspect we are going to get to a point where the 4 drugs may be where we stop adding more drugs to it.
I am not familiar enough with the data, and pardon me for this, but on the MRD data that you get a lot of MRD up front now. It's amazing. And then the role of autotherapy, auto transplant in the past was really to continue to debulk patients, right? And then to get them into a deeper response and longer disease-free survival. Now you have MRD negative patients. Are these patients still benefit from the auto?
That's a good point. If you look at the IFM-MET 2009 subset analysis, the benefit of transplant appeared to be there for all the subgroups, irrespective of the depth of response. The problem is we don't have prospective data to say that we can use MRD to de-escalate or escalate therapy in myeloma at this point. There are trials ongoing primarily in the post-transplant setting, trying to define the duration of maintenance based on the MRD status, and that's the SWOG study. There's also an ECOG trial that's looking at trying to escalate maintenance if you remain MRD positive after a year of Len maintenance. So I think MRD is a great prognostic tool, but we just haven't gotten to a point where we can say, okay, you are MRD negative, let's stop therapy. Even though 2 situations in the clinical practice that we still use MRD status. One is the high-risk patients where we try to chase MRD negativity by escalating therapy, at least to some extent, because that's only one characteristic that seems to make a difference in their outcomes. The second is patients who already are on continuous therapy, have some toxicity, and deciding to go off treatment. Getting an MRD negative result is kind of assuring both for the patients and the physicians when you are kind of already on the fence in terms of stopping therapy. Now, whether auto transplant will go away, I think that's a question we've been asking for 2 decades. I suspect until we can cure a significant fraction of patients, auto transplant's probably not going to go away. It's probably going to continue to play a role in the first couple lines of therapy, maybe not in the upfront therapy. It might move more and more to the second line therapy, as it has been for lymphoma. So we might be doing that following that same paradigm there.
Then a question on the immune status. We know that the MGUS and the smoldering myeloma, a lot of these, the progression factors is related to the lack of immunosurveillance or immunocontrol, I'm going to call it. And the data that is impressive of treating quote unquote earlier. Where do you see this is heading? And do we have any data on immune signature at baseline that help predict the outcome once you have a full-blown myeloma?
Yeah, so in terms of the progression, I think the changes in the microenvironment, particularly the microenvironment, is key to that progression we see from MGUS to smoldering to active myeloma. The problem that we face is, how much of that is modulated by the tumor cells versus, de novo change in the immune system. And that makes it harder for us to figure out, can we improve the immune surveillance independent of tumor control in order to achieve tumor control, or do we have to get rid of the tumor first before we can somehow regenerate the immune system to that status? Now, in terms of immune signatures, there have been, especially the Spanish group has published quite a few studies looking at the immune profile of patients who progress and the patients who don't progress, and have shown distinct differences. So clearly there is a degradation of the immune surveillance along the course of progression. And we know that at diagnosis, patients with active myeloma, even simple things like lymphopenia has been shown to be a significant prognostic factor. And this is a study, in fact, from a couple of decades ago now. So I think particularly the flow cytometry approaches have improved, and other technology like CyTOF, I think we are able to get a better sense of what that immune signature looks like. But it's still not mainstream, but I suspect it's increasingly going to play a role in that initial risk stratification, especially as we start moving these immune therapies to the upfront setting.
Without even talking about the portfolio that is very rich in myeloma, and you guys have done a great job in changing the disease, there's so many options to treat myeloma now. And so for our audience, I'm not aware that we have any clear data on sequencing yet, but can you comment on the studies that are ongoing, registry, MMRF, and all that, trying to answer these questions of the sequencing, and maybe we can create, instead of triplet, quadruplet, quintuplet, do alternate doublet. I'm just making it up.
Yeah, no, I think, the alternating therapy concept is, it's certainly the lymphoma approach there, and clearly has paid benefits.
You guys were doing the total therapy while we were doing the alternative therapy.
That's right. But I think the problem with the not exploring these alternating regimens have been because we really didn't have too many different drug classes up until now. So there are clinical trial efforts that are looking at using maybe a couple of different classes, alternating with another two classes in that initial therapy to see if we can actually get deeper responses without overlapping toxicities. But I think the challenge, as you mentioned, Andre, is the sequencing. We have so many different drugs, and I think if you can keep two principles in mind. One is try to use at least two active drugs, because I think the combinations always do better than just using one. And the studies, especially looking at the clonal evolution, has shown that if you are able to eradicate the clone or get it to a very low level, there is less of evolution over time. The second is, many of these drugs have toxicities, and some tend to last for a while. And so we have to be cognizant of that when we choose the next regimen. So whenever the patient's progressing, pick two drugs that the patients have not seen before, and preferably at least one of them from a class that they have not seen before. I know it's much easier to do that in the first 3 or 4 lines of therapy, and after that it becomes a challenge. And I think that's where we still continue to need these newer treatments with different mechanisms of action.
It's amazing that after decades of melphalan prednisone, and now how myeloma is a complex disease, it's remarkable.
Yes.
And congratulations for all the work that you and your team have done, and the whole community and the patients that have participated in these trials. I mean, changing the disease. I think that the finite therapy concept in myeloma is around the corner. Maybe not around
Abs-
the corner, but is in it, right?
I sure hope it will be, because especially if you're using 4 drugs, we need to be able to give patients treatment-free interval. I think that's important. And especially if patients are going to live 20 years with this disease, we don't want them to be spending 20 years on therapy. So we need to figure out how best we can hit and run approaches here, hit hard, get the myeloma under control, free of therapy for a few years before we need to go back to it.
Thank you very much. Thanks again for joining us today.
Thank you.
Our next presentation is from Dr. Camille Maddox. Camille is a professor of clinical internal medicine, lymphoma program director at the Ohio State University Wexner Medical Center. She has done a lot of work in the trained also at Mayo Clinic, so that's a good segue from our last presentation, but has done a lot of work in the relapse refractory large cell lymphoma, including outside of CAR T cells, and will share with us on how the field of large cell lymphoma is changing with so many options as well, both in the frontline and relapse setting. Camille, thank you for joining us.
Thank you for having me. Let me just pull up my slides here. All right. You can see those okay?
Yep.
Okay. Good morning, everyone. Thank you for the invitation to speak today on diffuse large B-cell lymphoma frontline and relapse outside of CAR T-cell therapy. So I think there'll be CAR T-cell therapy next week. These are my disclosures. So diffuse large B-cell lymphoma is the most common subtype of non-Hodgkin's lymphoma, and it's estimated that there were approximately 25,000 new cases of diffuse large B-cell lymphoma diagnosed in 2021, with about 11,000 patients with relapse refractory disease. Looking at kind of the history of treatment of diffuse large B-cell lymphoma, R-CHOP has been the standard of care for the initial treatment for patients with diffuse large B-cell lymphoma for over 20 years now. This was based on studies showing that adding the anti-CD20 antibody rituximab in combination with CHOP chemotherapy improved outcomes, including improvement in overall survival across patient populations. We know that with treating patients with R-CHOP, we cure about 60% of patients with their frontline chemoimmunotherapy, but that does leave about 40% of those patients who relapse or are refractory to their initial treatment. So over the years, I think as was mentioned a little bit ago, we've done a number of studies to try to improve the outcomes with R-CHOP chemotherapy. We've done things like trying to intensify the therapy using dose dense or infusional therapy. We've looked at targeting the heterogeneity of large cell lymphoma by adding different novel agents targeted more specifically to certain subtypes of disease, and have not seen benefit across population or in those disease subsets. And then we've changed therapy based on response. So looking at patients who are at higher risk of not responding or relapse, like patients with elderly patients or patients with high risk IPI, and looked at intensification with consolidation transplant or maintenance therapy after R-CHOP. And none of these have been shown to improve outcomes over standard R-CHOP alone. So I think this is an area that we are seeing an exciting advance in. This year at ASH, we saw results of the POLARIX study. So this was a phase 3 international randomized trial that randomized 875 patients to standard of care R-CHOP versus R-CHP plus polatuzumab. So substituted the vincristine for the antibody drug conjugate polatuzumab. This was conducted in patients with stage 2 to 4 disease with IPI of 2 or higher. Patients were stratified by IPI score, bulky disease, and then region of treatment. Just briefly, polatuzumab vedotin. So this is an anti-CD79B drug conjugate. It is approved in relapse refractory diffuse large B-cell lymphoma. I'll go over that data. And really should, in the relapse studies, was active across subgroups, and CD79B is expressed across B cells. So the primary endpoint of this trial was progression-free survival, and it did meet its primary endpoint, showing a 2-year PFS of 76.7% in patients treated with the RCHP plus POLA versus 70.2% of those treated on the standard of care RCHOP arm, leading to a 6.5% difference in PFS at 2 years. Now, there was no difference in overall survival with a median follow-up in this study of a little over 2 years, with 2-year overall survival being almost identical in the 2 arms. While ideally we would see an overall survival benefit in a trial like this, I do think with the current follow-up that it's not surprising that there wasn't an overall survival benefit. As we'll discuss a little bit later, there have been a number of agents approved in the relapse refractory setting. The agents we'll discuss in addition to chimeric antigen receptor T cells. And so I think that with the current follow-up, it's not surprising there was not an overall survival benefit. I think that still could potentially happen with longer follow-up, but of course remains to be seen. I think while this showed what could be described as a modest PFS benefit, one of the impressive things about this trial is that PFS benefit, while certainly it's always nice to see it bigger, really there was no difference in the safety signals in these arms. So you gained the PFS benefit without the expense of toxicity. So peripheral neuropathy was no different in the 2 arms, numerically slightly higher in the standard of care arm, but really no difference. There was a slightly higher risk of febrile neutropenia, both all grade and grade 3 to 4 in the polatuzumab arm, but this did not translate to an increased risk in infection. It did not translate to an increased risk of dose reductions or dose delays in the POLA RCHP arm. Growth factor was mandated on this trial, but there was actually a slightly lower number of patients, 90% versus who received the growth factor in the POLA arm versus the 93% in the RCHOP arm. This is the forest plot of subgroups. So looking and analyzing this by different subgroups, it did seem that potentially patients who were younger had lower risk disease by IPI of 2, bulky disease or GCB subtype may not have benefited from the POLA RCHP arm. But I think that this has to be taken with some caution because this study was not powered to detect a difference in these categories. And I think, in general, overall, this was a positive trial. And I do anticipate that this will be changing the standard of care in these high-risk patients with diffuse large B-cell lymphoma. This is currently not yet approved, although has been submitted to the FDA for approval. And again, anticipate this to be finally a new standard in frontline treatment. So I want to focus a little bit on some of the select populations in diffuse large B-cell lymphoma. So we know that patients with both overexpression of the MYC and BCL2 proteins and translocation of the MYC and BCL2 proteins have inferior outcomes with standard RCHOP chemoimmunotherapy. So those patients, particularly with translocations of MYC and BCL2, termed double hit lymphomas, have a median overall survival of less than 1 year when treated with standard RCHOP chemotherapy. It's been shown in several retrospective studies that intensification of therapy can benefit these patients, including dose-adjusted R-EPOCH, hyper-CVAD regimen, the R-CODAX-M R-IVAC regimen, a consolidation with autologous transplant in patients who are treated with RCHOP. There's been one single-arm phase 2 study looking at dose-adjusted R-EPOCH in these patients showing favorable 2-year PFS compared to that of historical controls. So venetoclax is an oral BCL2 inhibitor with rationale to use in these patients who have BCL2 translocations. A phase 1 study conducted of venetoclax plus dose-adjusted R-EPOCH in high-risk lymphomas determined the maximum tolerated dose with the addition of venetoclax to this regimen and showed promising overall response and complete response rate. So I want to highlight this trial that was presented at ASH, the Alliance trial. So this is a multi-center trial here in the US conducted through the intergroups. It's a phase 2/3 trial looking at the addition of venetoclax to chemoimmunotherapy for both double hit and double expressor lymphomas, but I'll focus on the double hit cohort. So patients were randomized to dose-adjusted R-EPOCH versus dose-adjusted R-EPOCH plus venetoclax. So this trial, the randomized phase 2 portion was actually closed early when they noticed a safety signal. The primary endpoint of the trial planned was PFS. After 73 of the planned 106 patients were enrolled, the trial was closed and an analysis was done to look at safety. And what they saw was an increased risk of death in the experimental arm, or the arm that added venetoclax to dose-adjusted R-EPOCH. So 70% of the patients on the standard of care arm were able to complete therapy versus 49% on the venetoclax plus standard of care. There was similar rates of cytopenias, but the patients on the venetoclax arm were less likely to be able to maintain dose level, increase dose level, and ended up with dose reductions. The rate of death, so at the grade 5 adverse AEs were 3.3% in the dose-adjusted R-EPOCH arm versus 17.1% in the EPOCH plus venetoclax arm. And it appeared that these were most related to infection events. So the PFS and overall survival in this study was in favor of the standard of care arm. So this trial was halted to accrual. The follow-up is short, but it is important to note in the standard of care arm that it appears that the outcomes with dose-adjusted R-EPOCH are favorable with the current follow-up we have. I think this is important, that while the phase 1 study did show that there may be a benefit to this, this is why we do these large trials. And we know that in these patients, one of the challenges can be getting in the primary therapy. And when we add these additional therapies, we can run into toxicity concerns. The last population I'd like to mention is the elderly population. So this can be a harder population to treat just because of the toxicities and their comorbidities. There was a phase 2 study looking at R-miniCHOP, which is essentially 50% of the doses of R-CHOP given in patients 80 or older, that showed a 2-year PFS of 47% and a 2-year overall survival of 59%. So we know the Phoenix study, that was one of those negative trials that we talked about, but this looked at the addition of the BTK inhibitor ibrutinib to R-CHOP versus standard R-CHOP alone. And this trial was a negative trial looking at the primary endpoint of EFS, but one of the things that was noted in this trial is that patients 60 and older had a much higher rate of SAEs and AEs leading to either dose delays, dose reductions, and discontinuation of therapy, suggesting that in this older patient population, it was really toxicity that was limiting outcomes. So there was a trial presented at ASH looking at ibrutinib plus R-miniCHOP in elderly diffuse large B-cell lymphoma. Patients were 75 or older. The primary endpoint of the trial was actually the 2-year overall survival, and they aimed to increase the overall survival from the previous R-miniCHOP study by 15%. So they did show that there was a improvement, statistically significant improvement in 2-year PFS of 60% versus the 47% seen in the other trial. 2-year overall survival, however, while numerically higher at 68%, was not statistically significant. I would like to highlight an ongoing trial that is being conducted in the intergroups in this patient population. So currently there's an ongoing 2-stage randomized phase 2/3 trial with a safety run-in, and this takes patients 75 or older, includes both high-grade B-cell lymphomas with translocations of MYC and BCL2 and transformed lymphomas, and randomizes them to standard R-miniCHOP versus R-miniCHOP plus CC486 or oral azacitidine with a 1-week priming of the oral AZA. There's a 40-patient safety run-in that's currently ongoing, and then after that they plan a randomized phase 2 with a primary endpoint of 1-year PFS and a randomized phase 3 with a primary endpoint of 2-year overall survival. The last thing I want to talk about in frontline is CNS prophylaxis. This has become somewhat of a controversial topic with emerging data over the past few years. So there's really no prospective data with CNS prophylaxis and diffuse large B-cell lymphoma, but we do know that there are certain populations of patients with diffuse large B-cell lymphoma who are at higher risk of CNS progression or relapse. Some of those populations of patients at highest risk include by location, so those with primary breast or testicular cancers, certain biologies, including the double and triple hit lymphomas, and then those with a high CNS IPI score, which is the International Prognostic Index IPI score, plus adrenal or renal involvement. And it's been shown that these populations of patients have somewhere between a 10% or higher risk of CNS or progression at 2 years post their therapy. So a study by Dr. Abramson previously had suggested that using intravenous methotrexate as CNS prophylaxis was better at preventing CNS relapse than that of using intrathecal therapy. And so this had become somewhat of a standard, I would say, to consider CNS prophylaxis in patients who would tolerate IV over IT in the frontline setting in these populations of patients. In the past few years, we've seen smaller retrospective data to suggest that there may not be a benefit to methotrexate prophylaxis, not just in the IT form, but potentially also even in the intravenous form. So this was one of the largest studies. Again, this is all still retrospective data, but this included over 2,300 patients from 21 international sites and took patients who were considered at high risk of CNS relapse by that CNS IPI, double or triple hit, and then primary breast or testicular location. Close to 20% of these patients received intravenous methotrexate as prophylaxis. When they looked at the 5-year risk of CNS relapse in the patients, 8.4% of the patients who had received IV methotrexate had CNS relapse versus 9.1% of the patients who had not received methotrexate. So no difference in CNS relapse in those who had or had not received IV methotrexate. Looking across the different subgroups of CNS IPI, double or triple hit, and primary breast or testicular, there was no difference across subgroups in outcomes with IV methotrexate either. Now, this is all still retrospective data, and we have no prospective data, but I do think that it brings into question, when you're using CNS prophylaxis, that you really need to select the patients that you're going to offer it to. It needs to be a discussion with the patients, and certainly the most important thing in the treatment of these patients is getting their primary treatment in, whether it be R-CHOP or dose-adjusted R-EPOCH, because this is just prophylaxis. And I think some of the trouble we run into is that when we try to give prophylaxis, we risk the intensity of the primary therapy. Now I want to move on to treatment for relapsed diffuse large B-cell lymphoma. And even though we're not talking about CAR T, we have seen a significant number of options approved in the last 3 to 4 years in this setting. And really the landscape here has changed from very minimal options, having chemotherapy and sort of palliative options to offer patients, to having a number of different options available for these patients. So the first novel therapy outside of CAR T that we saw approved was polatuzumab. As I mentioned, this is likely to be moved into the frontline setting and at least a population of patients with diffuse large B-cell lymphoma. But polatuzumab was approved in combination with bendamustine rituximab based on an 80-patient randomized study. This is the only trial in relapsed refractory disease that has actually seen an approval based on randomized data. The addition of polatuzumab to bendamustine rituximab showed an improvement in all outcomes, including overall response, complete response, median progression-free survival, and median overall survival. When you're looking at thinking about how to sequence some of these agents, we still don't have a lot of data there, but this is a pooled analysis of patients treated with this regimen, showing that the biggest benefit in progression-free survival and overall survival seemed to come when this was used earlier in lines of therapy. So patient who received this as second line had a much longer progression-free survival and overall survival than those who received it in third and later lines. Now, this is actually approved for patients who have received 2 or more prior therapies, although if you look at the NCCN guidelines, it is listed as a potential use in second or later lines. Toxicity of this in general, cytopenias and peripheral neuropathy. Peripheral neuropathy was all grade 1 to 2 and either improved or resolved after treatment. The increased rate of cytopenias did not translate into an increased risk of febrile neutropenia. Tafasitamab and lenalidomide is the only agent approved in the second line setting in diffuse large B-cell lymphoma, and this was approved based on a single-arm phase 2 study called the ELMINE study. This study evaluated 80 patients with relapsed refractory diffuse large B-cell lymphoma who were considered not candidates for high-dose therapy and stem cell transplant and who had received 1 to 3 prior regimens. This trial did exclude both primary refractory and double hit lymphoma patients, so excluded the higher risk disease subtypes. This trial showed an overall response rate of 60% with a complete response rate of 43%. Long-term follow-up of this study has shown that these responses in patients are durable with a median duration of response of 43.9 months, with median duration of response not reached in those patients achieving a CR. Median overall survival nearing 3 years. So really this immune doublet has shown to be effective in a subset of patients with diffuse large B-cell lymphoma. It's been shown to be best when used in the frontline treatment, and this is one of my preferred therapies for patients who are not going to be candidates for transplant or CAR T-cell therapy. Toxicity most largely was cytopenias, diarrhea, and fatigue, and very similar to what was seen with lenalidomide alone. Loncastuximab was the next approved agent. So this is another agent targeting CD19. This is an antibody drug conjugate that targets CD19 and was approved based on the LOTUS-2 trial, which was another single-arm phase 2 trial looking at this ADC and relapsed refractory diffuse large B-cell lymphoma patients who had received 2 or more prior lines of therapy. Looking at the LONCA population, so overall this was a little bit heavier treated population of patients there. This population included primary refractory, it included double hit lymphoma, and also prior auto and prior CAR T patients. The overall response rate in this trial was 48% with a complete response rate of 24% and a median duration of response of 10.3. When they looked at activity across subgroups, they saw that this was active across subgroups, including patients with double and triple hit lymphoma and including patients with prior auto CAR T, primary refractory, and disease refractory to last therapy. So this is really outside of CAR T where we have the best data in these patients with double hit lymphoma. And I would say a preferred option in those patients who are relapsed refractory with those characteristics and are not candidates or have progressed after CAR. Cytopenias and GGT increase were most common side effects with this agent. One of the challenges of having these CD19 directed therapies is knowing if we're able to sequence them. And at this time, I would say there's still very little data on this. Now that we have several CAR constructs approved, we have a CD19 monoclonal antibody, a CD19 antibody drug conjugate. Hopefully with use of these agents, we gain more data on responses in patients receiving one after receiving another. But I will just share the little bit of data that we have. So we know that patients, these are small numbers again, but they reported on 14 patients who have gone on to receive CAR T-cell therapy with either approved product or on trial directed at CD19 post receiving loncastuximab. And in those 14 patients, the overall response to CAR was 50% with 43% complete response, which is somewhat similar to what's been reported across the 3 trials of CAR in this setting. Similarly, small numbers, but 13% of patients who were treated on the Lonca phase 1 or phase 2 trials had received prior CAR therapy, and they showed that in those patients, there was a 46% overall response rate, similar to the entire population of patients, which had a 48% overall response rate. So we know that there are patients that after CAR, about a third of patients will lose CD19, and so in these patients, biopsying them to see if they still have that expression may be important, but really it remains unclear how we can best sequence these, and if using one of these is going to hurt the chances of responding to another. The last agent I'd like to touch on and was mentioned in the myeloma talk is selinexor. So this is the only oral agent approved in relapsed refractory diffuse large B-cell lymphoma, and this was based on the SADAL study, another single arm study with a primary endpoint of overall response rate. The overall response rate in this trial was 28% with a CR of 12% and a median progression-free survival of only 2.6 months. The median duration of response was 9.3 months, but the median duration of response in patients achieving a complete response was 23 months, suggesting that there's maybe a very small subset of patients who could have somewhat durable remissions from this drug. I think one of the important things to note in this trial is that patients were not allowed to have received prior therapy before enrolling in the trial from somewhere between 60 to 90 days. So when you're dealing with relapsed refractory diffuse large B-cell lymphoma, it's not a lot of patients that can go 2 to 3 months when they're progressing without needing another therapy, and suggesting that this was maybe these patients had less aggressive disease. The other challenge, this drug I would say has not overall is probably not utilized a whole lot, although again offers an oral option. The adverse events of this drug, so cytopenias, GI toxicity, and constitutional symptoms. It can take a fair amount of supportive care, including antiemetics, appropriate nutrition, and then TPO and GCSF agonists to be able to maintain dosing in these patients, and can just be a challenging drug to give. So this table just shows these approved agents. Again, it's a little bit hard to compare because there were different prior therapies. Some of the trials didn't allow refractory disease or double hit lymphomas, but all reasonable options in the right setting for patients. The last thing I want to highlight today is just a few of the more promising agents that are being developed. The first talk also mentioned bispecific antibodies. So these are exciting in lymphoma just as well as myeloma. The bispecific antibodies in lymphoma target the current 4 that have been studied target CD20 on the B cell, in addition to engaging the T cell. So we've seen results of 4 different bispecific antibodies in diffuse large B cell lymphoma. 3 of those are IV and 1 with subcutaneous use. These have shown overall response rates somewhere between 40 and 60% in aggressive large cell lymphoma, with complete responses ranging from 20 to 55%. They've also shown activity in the post-CAR setting, which can be a fairly challenging setting to treat patients in because those patients often have disease that can be unresponsive to several therapies. What remains to be seen in this population of patients with these agents is how durable these responses are. but currently they're not approved. I would anticipate that they'll be approved in the future, and they're already being moved into earlier lines of therapy, including frontline studies looking at these agents in combination with R-CHOP, RCHP POLA, and as single agent in the elderly population. These, like the CAR T, do have a risk of cytokine release and neurotoxicity, although with these agents, it's mostly grade 1 to 2 and not the higher risk toxicities. The last drug I'd like to last target I'd like to mention is the receptor tyrosine kinase like orphan receptor 1 or ROR1. There's an antibody drug conjugate called VLS-101 targeting ROR1, and this has been presented early, but showed in a phase 1 study an overall response rate close to 40% in diffuse large B-cell lymphoma, including activity in post-CAR patients with an overall response rate of 40%. Median duration of response, only 4.6 months in diffuse large B-cell lymphoma, but this is currently being evaluated in a phase 2 study in diffuse large B-cell lymphoma, so more to come on that. So this is just how I view the current treatment landscape for diffuse large B-cell lymphoma. Again, significantly evolved over the last 5 years. I've highlighted what's new since ASH. So I think that in the frontline setting, we'll have a new standard of care with RCHP plus polatuzumab. We know, and you'll see next week that we now have chimeric antigen receptor T cells available in the frontline or in the second line setting for patients who relapse within a year or are refractory to their primary therapy. And then, of course, all these novel agents for patients who are either not candidates for CAR or who progress after CAR. So getting to be a busy slide, which is good for our patients. And then very lastly, this is a big slide, but just a number of ongoing studies in the relapse refractory setting looking at different combinations with some of these novel agents that we've discussed. So a number with polatuzumab, venetoclax, selinexor, loncastuximab, the bispecifics, including glofitamab. And then I didn't touch on, but CD30, brentuximab vedotin in combination with lenalidomide is also being evaluated in a randomized study. So in conclusion, I would say that R-CHOP currently remains a standard of care in diffuse large B-cell lymphoma, but that's going to be challenged by the RCHP POLA data, and I do foresee that this will be approved in this setting. The therapeutic option at relapse have been rapidly expanding. We are seeing more patients cured of their disease, but at the same time, the fact of the matter is that the majority of patients who relapse will still die of their disease, and so we still have improvements to make in this setting. While we do have a number of options available, the optimum sequencing of these agents is not at all well defined. Novel immunotherapy, including bispecifics and CARs, which we did not talk about, will further the treatment landscape. There is a lot ongoing into improving efficacy, safety, and accessibility of the current products, but then also utilization of these agents earlier in the treatment landscape. We know that CAR is moving into the second line setting. It's been evaluated in high-risk patient populations in the first line setting. And as I mentioned, the bispecifics are currently being evaluated even in the frontline setting as well. Thank you.
That was very nice, Camille. We have a break for 10 minutes. And then we'll actually go over the discussion. There's so much happening in lymphoma. I remember when it was actually difficult, not that long ago, to really have novel therapies tested in large cell lymphoma because everyone was going to go into the standard hydroxyapatite transplant. And then if you use it in the salvage, the data were compounded by the transplant afterwards. So now this is really amazing what's happening in the landscape. And this is a real challenge because the 80% of the failures occur early, and these patients do very poorly with standard therapy in general, including auto. So this is very helpful. A lot of discussion. We have few questions. We'll reconvene in 10 minutes so we can do that debate. And thank you again, Camille, for presentation. Thank you.
Thank you.
Mike, if you want.
Ladies and gentlemen, at this time, we invite you to make your way over to the virtual booths. To join a virtual booth, head to the Sponsors tab under the Expo on the event homepage. You will see the companies who are sponsoring. To meet with a representative, select the company that you would like to learn more about from the list. On the right-hand side of the booth, you will see which booth staff are available to meet. Click the Meet Now button to meet with a representative.
Hi, Dr. Farmer. Hi, Dr. Gunenberg. How are you?
Ladies and gentlemen, welcome back from the virtual booths. Please welcome back Dr. Gua and Dr. Maddox.
Hi, everyone. Welcome back to our conversation. So we went over the data with Dr. Maddox on lymphoma, how the landscape is changing. And we have a few questions. So one of the questions as you mentioned, Dr. Maddox, we have been trying to really change our chop and break the ceiling for decades now. And although we had some data that was appealing in phase 2, very often in phase 3, as you mentioned, the data were not confirmed. And this is the first trial that has a positive thing, with a caveat that this is really a small PFS advantage, probably in a non-GC essentially. Again, that makes sense because of the targeting CD79 in ABC subtype of lymphoma. I was wondering on how you see the landscape, because the real issue in large cell lymphoma, we don't want to overtreat many patients with something that could potentially work, is really the early failures. As I mentioned, 80% of the failures occur in the first 18 months, and many of them are these high-grade lymphomas that are not necessarily double hit. So for your audience, when do you start to look if there is something that is like an aggressive high-grade lymphoma, because you don't have a fish all the time, and what raised the flag for you?
So, like at diagnosis, what are risk factors that?
Yeah, what raised the flag for you to really look for these high-grade lymphomas that we should manage probably differently?
Yeah, so I think that that's a good question, and it can be different by institution. So, as far as here, we do standardly test for MYC and BCL2 and BCL6 translocations, but many institutions don't have that ability. So I think one is just patient presentation. These patients with true double hit lymphomas typically present with aggressive disease, so high LDH, multiple sites of disease, multiple extranodal disease. Can be very symptomatic from their disease. They typically, when you look at the pathology, so some of the things that would be more standard to look at, they have high Ki-67. And then by IHC, you can look at overexpression. And so those patients who are GCB subtype with high overexpression of BCL2 and MYC are going to be more likely to be the double hit lymphomas and more likely to have those translocations. So when you're not able to send those in all patients, I think those are the patients that you want to really look for those translocations in. I also think that when you're thinking about that you do have, in these aggressive patients, I think there's time to decide. And by that, I don't mean time to decide what you're going to start them on, but I think it's always appropriate in these patients to give a first cycle of chemotherapy while you're waiting for the rest of the test. And even most of our trials now allow a first cycle of chemo to be given before enrolling on trial. So thinking about, getting that patient's disease under control by administering a cycle of R-CHOP or a cycle of EPOC, and then waiting for those FISH results, which can take up to a few weeks at some places, and patients don't always have that time to wait, and then deciding, what you're going to administer for the rest of the treatment.
Thank you. I mean, I think that this is an evolving definition, as you mentioned, and I think that as we have now the ability to include NGS, we do NGS in our institution. This is not done, I agree with you all the time, but I think it's important for audience to say that, to be aware that the patient who have, as you mentioned, high-risk features, particularly the non-GC with GC with a high Ki-67, are going to be double hit frequently. We know that 50% of the double hit by biology, quote unquote, gene expression profiling don't have the fish. So this pool of patient is probably expanding a little bit better, a little bit larger than we think. The other patient population that we don't address really is the p53 positive patients. And when you do this by NGS, we actually find even more likely than patients just by IHC. And I was wondering if you can comment on the p53 aspect also as another molecular high risk.
Yeah, I mean, I think that these patients, I agree that they're also high risk. I think the problem that we have is one that we're not universally testing for that. And, we're unlike in maybe some of the diseases like CLL, where we not only universally test, but we have treatments that we know can work better in those patients. We're just not there with, large cell lymphoma.
No, it's a really good point. I mean, there's so much to cover, but I think the data from Jason Westin group at MD Anderson is very appealing, looking basically you're sort of using the window approach that we do in mantle cell now, right? For these high risk molecular patients where they probably, you don't want to give the genotoxic right away and give a non-chemotherapy option in the beginning is not there yet, I agree, but this is appealing, and you're right, we need to have an answer.
Yeah, I mean, I think that that's very appealing. And I think the question really is, you know, how much of this window can you do? Maybe those patients need even less, because a lot of like his initial trials have given this window of therapy and then still given all the cycles of chemoimmunotherapy, and maybe those patients don't benefit from still all the chemoimmunotherapy, but more of the novel treatment. I think although we're not talking about CAR T, that trials like Zuma 12 are also highly interesting, right? So taking very high risk patients, looking at their early response to treatment. If they're not in an early CR, then escalating to therapies like the CAR T cells in those high risk populations, you know, makes sense and is of high interest.
So this is for our audience, again, this is really, there's a population that potentially should be referred for trials and all that. We know those patients are challenging, and we know that patients are going to do really well with R-CHOP, but definitely these patients don't do well with R-CHOP. It was interesting you mentioned the data from the R-CHOP venetoclax, the R-EPOCH venetoclax. And although the rationale was great because this was based on the Cavalli study looking at the BCL2 a double expressor patient, that there seemed to be a much higher CR rate, and that was the rationale. But it showed, as we had seen with the R-CHOP venetoclax, much more toxicity.
Yeah, I think that's been the challenge in some of our other randomized trials too, right? Like the rationale's there, but when we add these therapies to R-CHOP or R-EPOCH in these patient populations, and we're kind of sacrificing the dose intensity of the primary therapy, then we see that we get into trouble with outcomes, and it's because of the toxicity that these agents add to R-CHOP, even if they seem to be, you know, well tolerated as single agents, or maybe in other combinations.
And now I want to move on into the CNS prophylaxis. This is something, as you mentioned, that becomes controversial. I agree with you. Clearly, with the chemoimmunotherapy, we clearly, the low risk IPI don't develop a lot of CNS relapse. We still have this patient with high LDH, as you mentioned, and all that high risk features that can still develop this. There's this controversy, and then correct me if I'm wrong, but on the retrospective data that was presented by a couple of groups, looking at the IV methotrexate, which seems more logical and easier for patients, we didn't show any clear benefit, but I'm not sure that there was a dose cutoff on it was any IV methotrexate, and we know that we need to have a certain dose for CNS penetration to have prophylaxis. What's your take on that?
Yeah, so in one of the studies, they did look at like varying doses, although it could be anywhere from like 1 to 3 or 4 cycles of IV methotrexate. So the cumulative dose would have been less, but it could have been 1 of 3 or 3.5 grams. I personally have not like abandoned CNS prophylaxis based on this. I still think that in a young, you know, if you have a 40-year-old patient with a CNS IPI of 5 or 6, I'm still offering and, you know, giving them the IV methotrexate. I do think when you have, you know, a 65-year-old patient that you do have to think about, well, we're not really clear on the benefit, and there's certainly going to probably more chance of toxicity, more chance of delaying, you know, the subsequent cycles of R-CHOP. So I haven't given, I think that it's somewhere we don't have prospective data. We're probably not going to have prospective data. Hopefully in the future, things like ctDNA in the CNS will help us better decide these things. But right now, I do feel still that there's still a role in patients, and it should be discussed with patients. But I think that it has to be, you have to select your patient population.
You know, I think that I really like the way you put it, because I think this is a bit simplistic sometimes when you see these retrospective studies that say all of a sudden we're going to throw the CNS prophylaxis. So I think particularly the CNS relapse really occur in these high-grade lymphomas very typically. And then the typical course of a double-hit lymphoma, they do respond to initial therapy, intensive or EPOCH, but they very often have early failure and CNS involvement. So I think this is important that our audience doesn't take the message home that we don't do CNS prophylaxis anymore. The other thing that I had a quick question that I did not catch, and I'm sorry. The vincristine in the R-CHOP control arm for the R-POLA, which was pretty good R-CHOP control arm for high-risk patients, the vincristine was capped or not capped? It was capped.
It was capped.
Okay. And then in the relapse refractory setting, you had a lot, obviously you've been a lot involved in many of these trials. I thought it was really interesting, the data on the TAFA and the TAFA Rituxan and TAFA and Revlimid in a, comparing to CAR-T. And I think the importance of the real world data to really see the clinical benefit to start to tackle the question of which patient gets what.
Yeah, I think so. There was a Remind. So Remind 2 was a study that presented at ASH that was a little bit different kind of retrospective type study. So they use a propensity analysis. So they compared the population, the trial population of tafalen patients and matched by a number of disease and patient characteristics to retrospective data looking at patients treated with BR-POLA, R-squared, or CAR T-cell therapy. And they showed that there was actually an overall survival benefit to giving tafalen in this setting over BR-POLA and R-squared, with a median overall survival double the triple with the tafalen of that of POLA BR or R-squared. The overall survival was no different between the CAR T and tafalen population. So this is, a different kind of, you're comparing trial population to retrospective cohorts of other patients. They're very small numbers, but I do think what it shows is that, you're selecting patients for CAR T or you're selecting them for tafalen. And I think there are patients who are not candidates for transplant or maybe not candidates or don't have access to CAR T, who will have very durable remissions with the tafalen regimen. And in my practice, if I have an 80-year-old who's refractory or, relapses and they may be a candidate for CAR T, I'm not giving them tafalen because in the future they may be a candidate for CAR T when I could give them tafalen and, they have a 60% chance of responding, 40% chance of getting into a remission. And in many of those patients, the remissions were very durable. So I think this is, I think to me, they're hard to compare CAR T and tafalen because to me, they're a little bit different patient populations that you're really targeting. But I think that in the second line setting, tafalen is an excellent option for patients who are not otherwise candidates for more aggressive treatment. And there are a population of patients who are achieving durable remissions with this therapy.
We know that again that the patient who fail early in large cell lymphoma, and we know these patients do poorly. And although we haven't used another option, they're not really a cure. They're a great option because very durable response in some of these, and bispecific might even play a bigger role down the road. But I think referring patient for CAR T early before we give them Benda might something be important for our patients.
Oh, I 100% agree with that. And I think, if you're wanting to use polatuzumab as a bridge to CAR, I think you really need to not use it with the bendamustine. Once you've done the leukapheresis, if you want to give a cycle of the BR-POLA. But I think that if you're using that in the second line setting, it really should be in a patient that you're not thinking about sending to CAR or where you're not giving the Benda.
That's very helpful. Thank you for giving all your perspective. There's so much going on. And I think this is important that we are available, obviously, for all our audience to have a perspective and of what would be the best option for this patient, because we need to think on these patients who fail early, what are going to be our plan of treatment A, B, C, D versus just getting the next treatment that is available on du jour. So I think this is a great thing to have all these treatments, but we need to work together to make sure that we give the best sequence. Thanks.
I agree. Thank you.
Have a great weekend, and then looking forward for more progress on the next studies. Thank you. Now it's my pleasure to introduce Dr. Stacy Rifkin-Zenenberg, who is a colleague from Hackensack University Medical Center. Dr. Rifkin-Zenenberg is a program director in pediatric hematology oncology fellowship section on the pediatric oncology program at the Sansbury Children's Hospital at HUMC, and also assistant professor at the School of Medicine. She was the investigator in a study that we're going to hear about in order to finally bring gene therapy in hemoglobinopathy. So thank you for joining us, Stacy.
Thank you. And so today I'm going to talk about gene therapy and updates regarding sickle cell disease. My disclosures are that I'm on the advisory board for Global Blood Therapeutics. To start, I think that we have to review sickle cell disease. It's the most common monogenic disease in the world. It affects about millions of people worldwide. In the US, approximately 100,000 people are affected, with 5,000 people here in New Jersey. It's one of the most common monogenic life-threatening diseases. It's caused by a single point mutation of the beta globin gene, which causes glutamic acid to change to valine, causing adult hemoglobin A to change to sickle hemoglobin. Looking at the hemoglobin electrophoresis on the right, the non-sickle cell patient on the left shows the hemoglobin A greater than 90%, in contrast to the sickle cell patient on the right-hand side, who has the hemoglobin S of greater than 90%, which translates into what we would see on the peripheral smear on the lower left that would cause reversible and irreversibly sickled cells. This mutation from glutamic acid to valine causes the formation of hemoglobin S, and in the deoxygenated state will cause sickling, which results from the polymerization of hemoglobin S, causing irreversible and reversibly sickled cells, ultimately causing infarcts, microvascular occlusion, and end organ damage. Still, even in 2022, greater than 50% of the patients with sickle cell die before 45 years of age, and often this death is sudden because of the end organ damage. So this is why gene therapy has come to pass. There are two types of gene therapy. The first is using a lentiviral vector, and a lentiviral vector is a viral shell that can be used to package a gene, and it can be used in gene addition, which usually is adding a functional gene. The second type of the use of a lentiviral vector can actually be used in adding an RNA-mediated BCL to BCL11A, which induces hemoglobin F production. And then lastly, we can force LCR gamma globin looping, which also induces hemoglobin F production. So in summary, the lentiviral vector actually can either add a gene to ultimately make hemoglobin A production, it can induce fetal hemoglobin production, or it can reactivate hemoglobin F production. Gene correction is actually done through correcting with a functional gene by using a nuclease as scissors to cut out a mutated gene and insert a new gene into DNA. This can be done by CRISPR-Cas9, TALEN engineering, or zinc finger nuclease. The BCL11A enhancer can be disrupted with this, so it induces hemoglobin F production. And lastly, gene correction can also be done by making hereditary persistent fetal hemoglobin mutations, mimicking that genetic condition and causing the reactivation of hemoglobin F production. Allogeneic transplantation, we all know, is the only cure with high success rates for sickle cell, but the limited availability of matched sibling donors and the high risk of transplantation-related side effects force the community to look at curative therapies. Gene therapy on the left shows gene editing, where the enzyme represented by scissors cuts a piece of DNA and then assists reattaching a new piece of DNA into the helix. On the right, a corrected gene is packaged in a viral capsid and then enters the stem cell, then causing stem cell proliferation with a new gene, and healthy non-sickling RBCs are made. This cartoon shows ex vivo, which is defined as stem cells, which are harvested. They're modified with a lentiviral vector, and then they're given back to the patient after conditioning, where in vivo is when the genetic material, typically a functional gene, is packaged in a viral vector or capsid and then sent into the stem cell after the conditioning. And this can be done via CRISPR, TALEN engineering, or zinc finger nuclease. Oh, okay. This is the hemoglobin 206 protocol showing polyclonality correlating with the biologic and clinical outcomes comparing groups A and group C using the lentiglobin gene therapy. Lentiglobin is the lentiviral vector with the novel hemoglobin that was made to insert into the patient's stem cells. In this study, there were 7 group A patients who were greater than 18 and 35 patients in group C who were aged 12 to 50. The original protocol, which group A followed, was modified to improve the amount of CD30 plus cells harvested. They were transduced, which improved the gene product and ultimately the clinical benefit. The CD34 positive cells were bone marrow harvested in group A, and the patients underwent plerixaphore mobilization and apheresis in group C prior to the stem cells, which were transduced with a vector. Vector copy numbers, which is the measure of the transgene in the cells, and transduction efficiency, which is the percentage of transduced cells, were improved in group C, and pancellular expression of the novel hemoglobin was shown with a mean of 87% in group C at 18 months because of the improvements. Group C had severe adverse events of abdominal pain, nausea, opioid withdrawal syndrome, and vomiting, and there were no reports of malignancy in group C. One event of sudden death occurred about 18 months post-infusion in a patient with significant baseline sickle cell related cardiopulmonary disease. 2 events of AML occurred in group A at 3 and 5 years. Both are not associated with the lentiviral vector. Both had classic AML driver mutations identified post-diagnosis. So alterations in the protocol and manufacturing processing resulted in improved cell dose, transduction efficiency, the novel hemoglobin A production, and clinical outcomes in group C as compared to group A. So polyclonality strongly correlated with the peripheral blood vector copy numbers and the new hemoglobin production, indicating superior engraftment of the lentiviral vector transduced cells, leading to favorable clinical outcomes. The safety profile for the lentiglobin remains consistent with the risks of autotransplant, myeloablative busulfan conditioning, and underlying sickle cell disease. The companion study to this was a quality of life study. And this was because sickle cell has tremendous quality of life issues because of the vaso-occlusive crises, the progressive vasculopathy, the hemolytic anemia, and organ damage that results from the resulting in frequent hospitalizations, resulting in this decreased quality of life. So the ongoing 206 trial actually showed that these severe vaso-occlusive crises were completely resolved, and they had near normalization of the hemoglobin at the end of this, towards the end of 24 months on this trial in group C. If you look at these graphs, the lentiglobin shows meaningful improvement in quality of life of these patients. This abstract shows the baseline scores worse than the population norm that improves scores across all PROMIS 57 domains that were established early post-infusion and sustained to month 24. The mean values for patients overall indicated meaningful change at latest follow-up for all domains, including pain intensity, except for anxiety. So in summary, quality of life is improved in all domains of PROMIS 57 except for anxiety. This was published during ASH, and this is the ongoing results of this phase 1/2 hemoglobin 206 trial. The report is only of the safety and efficacy of group C. So 35 patients were infused and 35 engrafted. 25 patients could be evaluated. All had resolution of the vaso-occlusive events post-infusion. Hemoglobin increased up to 8.5 to 11 grams. There were no hematologic cancers observed in this group. In the left upper graph, the vector copy numbers, which is the way that we can follow the vector in the patient's blood, are maintained out to 36 months. The right upper graph shows the hemoglobin AT787Q, which is the new hemoglobin that the patients have in their blood, is maintained out to 36 months. This is then seen in the lower left graph in the red. And this actually shows that these patients become trait. And then in the lower right hand, you can see the pancellularity of the beta globin gene is maintained to greater than 87% 24 months after infusion. This is the MOMENTUM trial using ARU-1801, which is a gene therapy trial using a gamma globin lentiviral vector to produce a hemoglobin F G16D within the autologous stem cells. Preclinical studies showed that this mutation actually binds alpha globin with higher affinity, resulting in 1.5 to 2 times hemoglobin F per vector copy number compared to the wild type of gamma globin vector. This describes 3 patients who were between 19 and 35 years of age and were followed for greater than 12 months. The patients underwent reduced intensity conditioning with melphalan, which is different from the previous study, which was with busulfan conditioning. Transient neutropenia and thrombocytopenia were the adverse events, each lasting only 7 days. There were no other adverse events related to the chemotherapy. Patient 1 has stable hemoglobin F expression of 27% and 64% of fetal cells. Patient 2 had lower expression, which was thought to be because of trouble with maintaining melphalan levels because of issues with creatinine clearance. The third patient, if in the lower right hand graph, actually maintains a higher level at 36% of hemoglobin F with pancellular distribution and 96% of F cells because they made process modifications both in the stem cell collection and the lentiviral vector production before the patient 3 got the infusion. And since then, the patient 3 had no vaso-occlusive crises and had 100% reduction from baseline of their vaso-occlusive crises. ARU-1801 needs more follow-up, but the reduced intensity melphalan provides an interesting alternative to both stem cell transplant as well as the busulfan conditioning in the previous study and has a favorable safety profile. This is the PRECISION trial, which is the first in human utilizing autologous stem cells transfected ex vivo with a zinc finger nuclease mRNA, and this is targeting the BCL11A product. These 4 patients are reported after undergoing plerixafor mobilization and apheresis and busulfan conditioning, and the adverse events were consistent with the plerixafor mobilization and busulfan conditioning. And all 4 patients, as shown in the tables, had no vaso-occlusive crises post-infusion, increased their hemoglobin F, increased the percentage F cells, and had clinical improvement in all the PROMIS 57 domains. The CEDAR trial is the first in human trial utilizing autologous stem cells using the CRISPR-Cas9 paired with an adenovirus associated type 6 delivery template targeting the beta globin gene. The clinical trials produced greater than 70% hemoglobin A in vitro. This study will be looking at the safety and efficacy and pharmacodynamics of this gene therapy product. They're looking to enroll 15 patients, adults and adolescents, and they'll have plerixafor mobilization and apheresis. The difference with this trial is that they will have CD34 enrichment and cryopreservations, but they'll be doing it at the local sites. They will have busulfan conditioning, and the patients will be followed for 2 years. This study is ongoing. I think it's going to be a really wonderful study, but it is ongoing, so to be continued. This is another important abstract, which is in preclinical development. It's looking at a TALEN-based correction of the beta globin gene. TALEN stands for transcription activator-like effector nuclease, which is a restriction enzyme that can be engineered to cleave any sequence of DNA. This has been used only preclinically. It's resulted in 70% of gene correction. It doesn't affect the cell viability or differentiation of stem cells. It's up to 72% of the stem cells had correction of at least one allele. And it was observed to actually correct, to increase 60% of hemoglobin A and decrease the hemoglobin S from 90% to 19%. They had efficient expression of hemoglobin A translated to the sharp decrease of hypoxia-induced sickling rate of in vitro generated erythrocytes when compared unedited compared with the unedited cell globin 101 cells. And they also looked at the safety of this gene product and showed that there were not increased incidence of insertion and deletions. So in summary, we need to see more data on this very interesting type of gene correction. So hematopoietic stem cells gene therapy are curative for multiple genetic diseases, but are limited really by the morbidity and mortality of the cytotoxic conditioning. We've talked about conditioning with both busulfan and with reduced intensity melphalan. This abstract is talking about escalating doses of an antibody drug conjugate based conditioning with CD117, c-Kit, which specifically depletes stem cells and progenitor cells. If you look at the graphs, the granulocytes, reticulocytes, and platelet recoveries were the same both for the c-Kit and the busulfan. 2 months post-transplant, there was efficient gene marking. The vector copies and the granulocytes were observed in 3 of the 4 animals in the c-Kit conditioning. So the marking level was similar to the busulfan conditioning, and there was robust and durable hemoglobin F was similar for both. So a single dose of the c-Kit allows for efficient engraftment of the gene-modified stem cells in this rhesus monkey model. And this is targeted approach could be a safer conditioning model for gene therapy going forward. It currently is being trialed in by some drug companies as we're speaking. So because of the cases of AML that we previously talked about, clonal hematopoiesis is a hot topic. Bone marrow aspirates with NGS are being done for sickle cell trials that occur with the lentiviral vector. So this abstract that was presented looked at 4 patients who underwent autologous gene therapy using the lentiviral vector. Whole genome sequencing was performed pre and post, but in only 1 patient, they found 15 to 20 mutations 24 months after transplantation, which presumably were acquired from gene therapy or reconstitution post-transplantation, but no clonal expansion and no driver mutations for AML was identified. But we can't talk about clonal hematopoiesis with lentiviral vector without talking about CRISPR-Cas9 and the safety of this. So this reports on the potential safety issues with CRISPR-Cas9. This actually evaluated 4 gene editing targets on the beta globin, gamma globin, BCL, and BCL11A. What was found is that there were large deletions with very broad distribution of sizes, and there were large insertions of greater than 50 base pairs and large complex chromosomal rearrangements at the Cas9 sites. These deletions were unintended and occur at high rates in all gene edited sickle cell, hematopoietic stem, and progenitor cells. These raise significant safety concerns with patients who are undergoing CRISPR-Cas9 gene editing therapies. So the future, what does it hold for gene therapy? Antibody conditioning seems a fabulous option for conditioning for those patients undergoing gene therapy. There is hope for FDA approval for these gene therapy products in adult patients, and we're looking forward to pediatric trials.
Thank you. This is a really exciting field as well that could change the lives of people who have a very chronic disease, truly miserable from admission back and forth and chronically anemic and so on and so forth. So that would be very, very, very impactful. I have a few questions. Was wondering from your experience, we don't have a long follow-up obviously, but what's the longest follow-up we have on these patients who have improved their hemoglobin? And the improvement, and I'm sorry if I don't know the data well, if the improvement in hemoglobin, once they respond, quote unquote, it stays stable, correct?
The patients that we have so far are 2 years out of the original study, because we're now the patients, we had 3 patients that participated. We had 2 patients in the that participated in the 206 study. The earliest patient was our pediatric patient. He's 2.5 years out of the study, and he's maintained 11.5 hemoglobin for 2 years and has had no crises.
That's amazing. I mean, no crisis, therefore no pain and all that. It's transformative.
No.
Do you see the obviously the concern is safety? Everyone with a history of gene therapy that has slowed down the process quite a bit over the years. So how do you see the technology that we're using now, quote unquote, safer comparing to prior vectors that were used and secondary malignancies?
I definitely think that, knowing the history of everything, I think that we have to be very careful. I think we're doing bone marrow testing on every single patient. We're learning more and more by doing all of the NGS screening on every patient. I think we definitely know more than years ago when things were done with the SCIDS patients many years ago and everything was stopped. But I think that we're doing our due diligence. And I think that for now, I think that we're as safe as we can be with what we're doing. And I truly believe in this. For patients who are, over 12 years old, I think that this is a great option, because I think that if you don't have I think that, with all of the side effects of chemotherapy and with the side effects of transplant, this is a great option. I think that under 12 years old in pediatrics, we still have some great options with match-related siblings, and even with the unrelated transplants in pediatrics, if a patient is on a clinical trial, we do have some good options.
Also did on cord blood in that setting, and I'm sorry that I don't follow that.
Yeah. What?
Cord blood transplant in that setting.
The
cord blood transplant in that setting, because you don't have always a donor. So these are young patients, a small GABA rate, so they could get a cord blood transplant. And what's the
cord blood? So yeah, but even with cord blood, I mean, so the cord blood transplants, we still are doing cord bloods. Even the patients who are getting match-related siblings and getting cords from their siblings, we're still waiting until the baby is 1 year of age. So we still are adding some of the child's to their cord. And we're still doing match-related is absolutely the best type of transplant for a patient. Even if a cord unrelated is not really going to be better than a.
And what's you alluded to the AML of the few AML, the 4
Yes.
AML patients
So
that had classic AML drivers, but you had also some patients with mutation that were not AML at risk, if you want to call it.
So the driver mutations that were found in the AML patients were RUNX1 and PTPN11. So they are like classic AML drivers. What they found was that the patients, those 2 patients clearly had those, and they felt that this was as a result of busulfan conditioning, and that's why these patients were the AML. They had multiple people doing studies on the patients, and they felt that this was not because of the lentiviral vector. The lentiviral vector actually was inserting in the VAMP4 gene, and the VAMP4 gene insertion site is, a vector-associated membrane protein. That is where the patient, because we do insertion site analysis on patients when we do gene therapy, and we actually do routine studies to see where the gene product is actually inserting. And we're looking for unique insertion sites, and we're looking to see if there's any clonality to those, or if they're polyclonal and unique, if it's polyclonal and unique insertion sites. So
typically this is a diverse insertion site.
Yes.
Okay.
Yeah.
This is really fascinating. I mean, I think this is a whole new era for the field, and we hope that this is going to continue and expand in other diseases and serve as a model. Thank you. Really appreciate it.
Thank you.
Thank you for joining us. It is my pleasure now to introduce another colleague of mine, Dr. Harsh Parmar, and we'll have Dr. Noah Biron joining us as well for that presentation. And Dr. Parmar is Adjunct Cancer Center in the myeloma division and has a great focus on obviously on myeloma, but also amyloidosis. He's going to talk to us about this morning about recent abstract that can bring new options in the context of refractory multiple myeloma. Dr. Parmar, thank you for joining.
Yes, hi, good morning, everyone, and thank you for having me today.
You're going to share your slides, right?
Yes. Can you see my slides?
Not yet, but they're in process in cyberspace, I guess. Not even cyberspace because it's on the Zoom.
So can you see the slides?
Not yet. You have them open and share the screen. Here we go.
Yeah.
Perfect. Thank you.
Yes. So good morning, everyone, and thank you for having me today. Dr. Kumar earlier gave us an excellent talk reviewing the current treatment paradigm of myeloma therapy that has changed quite significantly over the past several years. So I will review and talk about the updates presented at ASH 2021 for patients with relapsed myeloma. I have no disclosures. So we have been very successful in treating multiple myeloma patients in terms of inducing deep remissions in the newly diagnosed setting as well as in early relapse setting. However, there is a large unmet need in terms of late relapses, at which point the disease becomes very hard to treat. I have divided my talk into two parts. I will initially talk about the updates presented at ASH 2021 for early relapse and then for late relapse. So for early relapse, there were some interesting abstracts presented. The first one provided a sequencing strategy looking at selinexor treatment for patients with daratumumab refractory population. And the other abstract looked at combining selinexor with daratumumab, bortezomib, and dexamethasone, which was a phase 2 study performed in Spain. So using ex vivo drug sensitivity and RNA sequencing data, a therapeutic strategy was studied by Dr. Praneeth Reddy and colleagues. Data for mutations associated with sensitivity or resistance for several anti-myeloma drugs were collected. Selinexor and daratumumab, interestingly, were noted to have an inverse correlation in their mutational profile, which means that mutations that rendered resistance to daratumumab predicted for sensitivity towards selinexor and vice versa. For instance, one such mutation that was identified was MYC expression, which was associated with resistance to daratumumab but sensitivity towards selinexor. Therefore, they theorized that patients who were relapsing on daratumumab would have better outcomes if they were challenged with a selinexor-based therapy subsequently. So this theory did translate into a clinically meaningful result in that the progression-free survival, when the progression-free survival was assessed in 2 prior clinical trials, patients who had received a daratumumab-based combination immediately prior to selinexor had a better outcome compared to those who did not. For instance, in the STORM trial, if you see, patients who had immediate prior line of therapy with daratumumab had a better outcome with a PFS of 15 months compared to 9 months for those who did not. And similarly, in the XPORT MM28 trial, the outcome was found to be similar in terms of improvement of PFS with prior data-based therapy. So in summary, daratumumab resistance was associated inversely with selinexor sensitivity, which was clinically validated in outcomes for PFS in clinical trials. Increased MYC expression was associated with increased sensitivity with selinexor. And this also potentially provided rationale for combining the two drugs, which was tested and provided an overall response rate of 73% as per data published in EGH 2020 by Gasparetto and colleagues. A similar combination was studied in Spain, where patients were divided into two parts to receive the combination of daratumumab, Velcade, and dexamethasone with selinexor. In the first part, patients had received 3 prior lines of therapy. In the second part, patients had received 1 prior line. For the first part, the overall response rate was found to be 50%, with a median progression-free survival of about 7 months and a median OS of about 28 months. In part 2, a higher overall response rate was observed as expected at 82%, and the median PFS and OS were not reached. In terms of toxicity, cytopenias were noted, particularly thrombocytopenia. GI toxicity was also found to be common, with nausea being the most common GI event. Clinical outcomes in patients with dose reduction of selinexor with bortezomib and dexamethasone was tested in the Boston study, and an analysis was performed with reduced dosing of selinexor to see how the outcomes play out. And another abstract which was interesting was the safety data and efficacy data presented for the combination of venetoclax, daratumumab, and dexamethasone. So the Boston trial evaluated the efficacy of the combination of selinexor, Velcade, dexamethasone compared with Velcade and dexamethasone alone. And there was an improved PFS noted of 14 months compared to 10 months with the seli-based combination. As we know from our clinical experience, selinexor is frequently associated with several side effects such as GI toxicities, fatigue, and cytopenias. And this is commonly found in higher doses of 100 milligrams administered once a week. So this was an analysis of the Boston study where they compared the reduced dose of the selinexor with a median of about 70 milligrams once a week compared with the standard 100 milligram dosing. And what was interesting here is that patients who had received a lower dose ended up having an improved progression-free survival of about 16.6 months compared to 9 months for those patients who did not have dose reduction. Even in terms of the overall response rate, you found a better responses with the reduced dose arm at 82% compared with 67%, which suggests that patients who had reduced dose selinexor tended to stay on the treatment for a longer period of time, and as a result had longer and a prolonged exposure to drug compared to those who did not, and therefore they had better outcomes. The current study is evaluating the role of combination of venetoclax, daratumumab, and dexamethasone. Data for part 1 showed excellent responses for patients with translocation 11-14 myeloma, and part 2 irrespective of the 11-14 status. And data for part 3 was presented that is currently comparing the efficacy of venetoclax, daratumumab, dexamethasone versus daratumumab, Velcade, dexamethasone. And the preliminary results presented showed excellent efficacy of this combination, yielding a response rate of close to 100% at the target venetoclax dose of 800 milligrams. Even with 400 milligrams, you see good efficacy with response rate of 73% in comparison with the daratumumab, Velcade, Dexam, where the response rate is closer to 60%. Although this particular cohort had 2 prior lines of therapy compared to the 1 median prior line of therapy with the other 2 arms. Having said that, the combination of venetoclax with daratumumab was found to be safe, although the risk for grade 3 neutropenia and febrile neutropenia was higher with the venetoclax-based combinations. Now, looking at the late relapses, there were several exciting data presented at ASH 2021, which will likely change the paradigm of myeloma therapy in the near future in this setting. So data for CARTITUDE-1 was initially presented at ASH 2020 that showed an excellent overall response rate approaching close to 100% and a 12-month PFS rate of 77%. And this was for the group of patients who are heavily pretreated. In the most recent updated results that were presented at ASH 2021, the impressive results continued to show us impressive outcomes. So this was an early phase study, and as I mentioned before, this was a heavily pretreated population with a median of 6 prior lines of therapy, with more than majority of the patients being triple-class refractory, and almost half of the patients being pentadrug refractory, which means refractory to 2 different PIs, 2 different IMiDs, and a monoclonal antibody. And in spite of that, we found an overall response rate of 98%, with an 18-month progression-free survival of 67% and an overall survival of 81%. Even when it came to MRD negativity, we found a sustained MRD negativity at 6 and 12 months of 96 and 100% respectively. And we know that MRD negativity is a good surrogate marker for progression-free survival. The treatment was well tolerated overall. CRS occurred in majority, actually more than majority of the patients, but most of them were found to be grade 1 or 2 and easily manageable. An adjusted comparison of outcomes was made between patients enrolled on CARTITUDE-1 with therapies offered in the real-world clinical practice across various different countries in Europe and the United States. These commonly used therapies included combinations of carfilzomib dexamethasone, Pomalyst Cytoxan dexamethasone, and pomalidomide with dexamethasone. And when looking at the adjusted comparisons for stage of myeloma diagnosis, the median lines of prior therapy, as well as the ECOG performance status, we find that the outcomes were in favor of CAR-T compared to the standard therapies, with a significant improvement of overall response rate, complete response rates, PFS, as well as OS. Looking at other CAR-T constructs which were studied and the data of which were presented at ASH 2021 included a phase 1 study of CRB-402 or BB21217, and another phase 1 study looking at the CT103A CAR-T. Ide-cel was the first anti-BCMA CAR-T therapy approved in March 2020 based on data from the KarMMa trial. In the most recent update presented at ASCO 2021, the median progression-free survival was found to be around 9 months. The lack of persistence of anti-BCMA CAR is known to be associated with disease progression. Therefore, one of the strategies to overcome this problem was to try to improve the persistence of these cells. So BB21217 uses the same CAR-T construct as Ide-cel or Abecma, which is currently FDA approved, but adds to it a PI3 kinase inhibitor 007 that increases the persistence of T cells by inducing a memory T cell phenotype. The improved CAR-T cell persistence was observed with this study, with 81% of patients showing detectable level at 6 months and 60% of the patients showing detectable levels at 12 months. This is in comparison to about 60% persistence at 6 months for the original BB2121 and 21% at 12 months. Looking at the CT103A, which was a CAR T trial performed in China, patients had a median of 4 prior lines of therapy. They had an overall response rate of 96%. 75% of patients had sustained MRD negativity at 6 months, and detectable levels of cells were noted in almost 90% of patients at 6 months and 88% of patients at 12 months. So this is a brief summary slide of the different CAR Ts. We find very impressive results with CAR T therapy in heavily pre-treated myeloma population. Low risk of grade 3 toxicities and CRS was noted, as well as neurotoxicity compared to some of the other hematological malignancies such as lymphomas and leukemias. The response rates vary anywhere between 70 to 100% depending on the product used. Responses are noted to be durable between 18 and 24 months. One of the concerns frequently expressed in the myeloma community in regards to CAR T is the timely access to this therapy. About 70% of patients with myeloma are treated in the community setting in the United States, and this could potentially limit access to CAR T, which is available in higher or academic centers. This is where molecules such as BiTEs may very well become practically important. So now I will talk about the different BiTE molecules which were presented with various different specificity towards receptors. So I will talk about Majestic-1. The updated results of Majestic-1 trial were presented at ASH 2021. So teclistamab is a BCMA-directed bispecific T-cell engager. Patients in this study had received 5 prior lines of therapy. 77% of the patients were triple-class refractory. About a third of these patients were penta-drug refractory. We found an overall response rate of 65% in this cohort of patients. CRS was reported in 70% of patients, but almost all were early grade events. 4 patients experienced neurotoxicity. And responses were also noted to be durable at 6 months. Daratumumab, in addition to being a potent anti-myeloma therapy, is also known to have immunomodulatory effects, including T-cell expansion. Since we utilize the cytotoxic T-cell properties with this bispecifics, it provides a good rationale to combine the two. The combination of teclistamab and daratumumab was therefore studied in this phase 1 study. Patients had received 5 prior lines of therapy. Majority of the patients were triple or penta-drug exposed. CRS was noted in about half of these patients, and no grade 3 events were noted. There was no neurotoxicity, although there was an increased incidence of infections. Responses were impressive, with all 4 patients showing a response at the higher teclistamab dose with dara. The study is still ongoing, and we will have the updated results in the subsequent meetings. Looking at other BCMA-directed bispecifics, we have the first one, which was a phase 1 study of TNB-383B, which was a BCMA-directed bispecific T-cell. Patients had received a median of 5 prior lines of therapy, with the majority of the patients being triple-class refractory. CRS was noted in about 70% of the patients. We found an overall response rate of about 80% in this entire set of patients, with a CR rate of about 30%. In the subset of patients with triple-class refractory disease, an overall response rate of 55% was noted with a CR rate of about 7%. So again, a very active molecule. Elrantamab is another BCMA-directed bispecific T-cell engager, and we had the updated results presented to us from the MagnetisMM-1 trial. Most patients in this study received elrantamab as a single agent. 4 received it as a combination with lenalidomide and 4 with pomalidomide. Patients had received a median of 6 prior lines of therapy. Almost all of these patients had triple-class refractory disease, and about half of patients had a stem cell transplant previously, and 20% of patients also had prior BCMA therapy. CRS was reported in 83% of patients, and no grade 3 event were noted. Cytopenias were also observed. Overall response rate of 70% was reported with a 30% stringent CR. In addition, we have another BiTE with a unique receptor target outside of BCMA, which is talquetamab. And we had the results reported for talquetamab as a single agent as well as in combination with daratumumab. So GPRC5D is the target utilized by talquetamab. This is found to be expressed at a very high frequency in the myeloma cells. So talquetamab has a specificity towards GPRC5D. In this study, the dose of talquetamab was evaluated at 405 micrograms per kilogram once a week, or given as 800 micrograms per kilogram biweekly. The overall response rates were similar between the two groups at about 70%, and the safety profile slightly favoring the biweekly dosing with a lower incidence of skin and myelotoxicity. And more than majority of the patients here were triple-class refractory, with several patients also receiving prior BCMA therapy. As a single agent, talquetamab, as we saw, produced a high response rate. So when combined with daratumumab, we would expect to find even higher responses, given that daratumumab has immunomodulatory effects. In this study, the combination was studied. Patients had 6 prior lines of therapy. More than a majority were triple or pentaclass exposed. Adverse effects in form of dyschezia and scale exfoliation were noted. CRS events were also noted in about 33% of patients, all of which were likely attributed to talquetamab. Impressive responses were noted once again, particularly with the 800 micrograms biweekly dosing, with about 7 out of 8 responders, which translates to about 85 to 90% response rate. The study is still ongoing. We have 2 other BiTEs data which were presented at ASH 2021. We had the Regeneron 5458, which was another BCMA-directed BiTE, and then cevostamab, which has a unique target in form of FcRH5 receptor. So Regeneron 5458 data was presented. In this study, patients with 5 prior lines of therapy, with majority being pentarefractory, had an overall response rate of 73%, with lower incidence of CRS of about 40%. No grade 3 CRS were noted, no neurotoxicity was reported, indicating a favorable safety profile. Responses were noted to be durable, being greater than 8 months or even as long as 19 months. What was interesting was that disease response was found to be independent of the level of BCMA expression. So cevostamab is a BiTE with specificity towards the FcRH5 receptor expressed on the plasma cell and CD3 receptor on the T cell. The FcRH5 receptor is known to be expressed on almost 100% of myeloma cells and in abundance, thereby making it an attractive target. With this study, patients had received 6 prior lines of therapy, and more than a majority of patients were triple-class refractory, and several of them actually had received prior BCMA-directed therapy. We found an overall response rate of 55%. For patients with prior BCMA-directed therapy, an overall response rate of anywhere between 35 to 50% was noted, depending on the type of BCMA molecule used. So this would give us yet another option for patients with relapsed refractory multiple myeloma, particularly those who had received prior BCMA therapy. So in summary, BiTEs are very efficacious. They produce an overall response rate ranging anywhere between 60 to 80% with the BCMA-directed BiTEs, and an overall response rate of about 60 to 70% with non-BCMA targets. They are well tolerated, although the incidence of CRS is high. Almost all were noted to be of low grade. So BiTEs give us a possible alternative to CAR-T, which is less accessible in the community setting, and they are also off the shelf and therefore readily accessible. As a result, patients can initiate therapy quickly, particularly in those subset of patients who are relapsing aggressively. Another class of drug of significant clinical interest is the CELMoDs, and one of these drugs is called iberdomide or CC220. And the results from the dose expansion phase were presented to us. And lastly, TAC573, which is an anti-CD38 attenuated interferon alpha fusion protein. So CELMoDs are a new class of agents that appear to be more immunologically active than the historic IMiDs. One such agent is CC220 of iberdomide. And this produced an overall response rate of 25%. The set of patients in the study were heavily pretreated with a median of 6 prior lines of therapy, with almost all being triple-class refractory. One can expect a higher response rate if and when this drug is moved to a more upfront setting, and there are trials ongoing looking at combinations of iberdomide with carfilzomib, daratumumab, as well as bortezomib. So putting this into context, historically speaking, daratumumab as a single agent produced a response rate of 29%. And when it was moved to a more upfront setting and in combinations, the response rates have increased to over 90%. So one can expect a similar outcome for iberdomide as well. Historically speaking, systemic interferon alpha was used many years ago in treatment of myeloma, which produced many off-target, unwanted side effects such as severe flu-like illness, psychiatric issues. TAC573 or modakafusp is an immunocytokine that binds to the CD38 receptor expressed on the surface of plasma cell and releases interferon alpha intracellularly that essentially prevents multiplication of the plasma cell. And therefore, it has some specificity towards myeloma. In this study, the safety and efficacy of this molecule was evaluated, and an overall response rate of 40% was noted for these patients who were heavily treated with 7 prior lines of therapy. So in summary, the treatment paradigm for multiple myeloma is changing quite rapidly. Several decades ago, we used to use chemotherapy, and we've moved away from that. We've started using novel agents such as proteasome inhibitors as well as IMiDs. And now we are moving towards immunotherapy that involves the use of CAR-Ts and BiTEs, which have produced very promising results. And there are newer targets which are being identified outside of BCMA, and therefore our armamentarium is also increasing in size. Newer drug classes have been identified, including CELMoDs and immunocytokines, which will likely become integral component of anti-myeloma therapy in the near future. So with that, I will conclude my presentation, and I'll be open to questions.
Thank you very much, Dr. Parmar. And Dr. Biron is going to join us and moderate this session. And I will ask our audience some more questions because we are fortunate to have two experts in myeloma, and Dr. Biron in particularly from the John Terry Cancer Center, who has been very instrumental in a lot of these trials. Thank you, Noah, for joining.
Good morning, everybody. Thank you very much. And thank you, Harsh, for a very thorough summary of all the novel therapies we have at our armamentarium for treatment of patients with myeloma. And certainly, we're lucky to have agents in early and even late relapse. And there's a lot of questions that at least that I've thought of during your presentation. So I guess I would start with, in the early setting, many of the trials, specifically the ones that are selinexor backbone, do not include patients who are IMiD refractory, specifically lenalidomide. So how do our oncologists who are treating patients with lenalidomide maintenance interpret some of these overall response rates? Because these patients certainly are not len sensitive. So do you think we should still be considering these regimens in len refractory patients?
Yes, absolutely. I think it's important to combine selinexor with IMiDs, and particularly pomalidomide, and the combination of selinexor and pomalidomide has been studied in the setting of a clinical trial with the STOMP. And one of the abstracts that I talked about that included the sequencing strategy, particularly daratumumab, also points towards the evidence that it would be an attractive target for patients who've progressed on daratumumab and lenalidomide-based combination. So usually after post-transplant in the first line in the second line setting, we like to use either dara-Revlimid dex or dara-Pomalyst dex. So for patients who progress on these combinations, one can certainly think about using selinexor with pomalidomide and dexamethasone, in that we know from this abstract that if you have resistance to daratumumab, it may actually indicate sensitivity towards selinexor depending on the mutations.
And how are you using your anti-emetic regimens and surveillance of patients who are on selinexor?
Right. So, we know from our experience as well as from trials that nausea is one of the chief side effects when it comes to selinexor. So what we usually do in our clinical practice is we give a long-acting anti-emetic, such as aprepitant IV, every other week, and we combine it with round-the-clock usage of either compazine or Zofran on the days that patients take selinexor, and perhaps at least 2 days following that. And we also add or encourage patients to take Zofran on top of that. And this strategy seems to decrease the incidence of nausea and other GI toxicities.
I think it's very interesting that there was an increase in response to patients who had overexpression of MYC to selinexor. And I'm wondering if you think myeloma is heading more toward a personalized medicine approach rather than a guess and test. Specifically, you can speak toward venetoclax and as well.
Yes. So I think I completely agree. We are moving more towards precision medicine when it comes to myeloma. As you correctly pointed out, in patients with translocation 11;14, or even in patients who have high BCL2 expression, tend to have better responses with venetoclax. And this data was presented by Luciano Costa, studying the combination of venetoclax with carfilzomib. we found that responses were not only restricted to patients with translocation 11-14, but also for those group of patients with higher BCL2 expression. And yes, this was an interesting finding when it comes to selinexor as well, that if you have increased MYC expression, that renders sensitivity towards selinexor, and it can potentially be considered as a possible concept for a study moving forward.
I have a question for both of you here. The MYC in myeloma is something that we see over time after clonal selection in multiple 3D patients, or this is something you found some patients who have subset of more aggressive biology from the get-go? Noah.
It increases with each relapse.
Okay.
It is more commonly seen in higher risk, concomitantly with higher risk mutations by FISH1Q, 13q deletion in later relapses, and correlates with increased BCL2 expression by PCR also. So I think that, and that clinically explains why we do see responses with selinexor in late stages and restoration of response. Even in patients who are refractory on their current regimen, we have a trial where we're adding selinexor to a patient who's already progressing on an IMiD or PI backbone. And so we want to know, is there a response? And it, that will explain why. So
that's interesting.
Yeah. So let's talk a little bit about the relapse, the later relapses. And it's hard really to compare across trials, but when you see some of these trials in late relapses, what is the measure that kind of equalizes across trials? Is it high-risk cytogenetics? Is it triple refractory? What do you think it makes the patients, most likely not to respond to therapy in the late relapse setting?
Right. Yeah. I mean, one is the biology of the disease, and of course, the median lines of therapies also matter. So if the patient has seen more lines of prior therapy, different classes of drugs. So if you have triple class refractory or penta refractory, which would be worse than triple refractory, the outcomes would, in that case, be poorer. So yeah, I think the disease biology, for one, dictates it, the intrinsic disease aggressiveness, and two, also the amount of therapy that the patient sees over time.
Can you speak a little bit toward T-cell redirecting therapy? For example, a patient who's already progressed on a CAR T-cell, would this patient be a candidate for a bispecific T-cell engager or a Takeda molecule?
Yes. Yes, absolutely. I think if a patient has seen CAR T therapy, one of the issues with CAR T therapy that we know of is that persistence of the cells is an issue. So if with time the cells deplete in the individual's body, then you do not have any active molecule suppressing the myeloma. So in that case, you can overcome this disadvantage by giving someone sustained therapy over time directed against BCMA. So BiTE would offer that advantage because you continue the therapy and try to keep myeloma under check. Another way, as I talked about or in my presentation, is to increase the persistence of cells. So one such strategy was explored with the BB21217 CAR T construct, where the persistence of cell was found to be higher compared to the original product. And that did translate into an improved progression-free survival. So yes, you can certainly sequence patients with BiTE following anti-CAR BCMA-directed therapy.
Yeah, and we see in one of the bispecific T-cell engager studies that a large subset were BCMA refractory, and despite that had a signal of response. So I think that's very exciting that you can kind of recycle these immune-based therapies and repeat them, and I think we're seeing some of that.
So they had failed CAR T, BCMA, and responded to bispecific?
Yeah, 30% had already failed a BCMA CAR T, including it in the trial with response rate 45%.
Yep, very impressive.
Very exciting.
A question on philosophy, because you have so many options now in myeloma. I mean, obviously you guys have done so many trials and pushed the needle. It's amazing. How do you, as a practitioner for our audience, how do you pick in a relapse setting? That's what we're focusing now. You take doublet in a relapse setting, or you take a single agent and try to go from one single agent to the other based on what they had before? How do you choose? And there's so many options.
So doublets are pretty much out in myeloma in the relapse setting, and even in the newly diagnosed setting. The triplets for sure are better than doublets. The question is, if you do a triplet, and can you add a quad later, or start with the quad, is really where the field is going. And so there have been trials where you start with 3 drugs and then add a fourth, like POM, Dara, Dex, and then add Cytoxan, or do all 4 at once. And it showed that if you start with 3 and then add the fourth upon progression, you really get a similar PFS. It's maybe very short difference, very small difference. So definitely triplets because of the heterogeneity of the disease, but maybe.
But now you have a multiple different mechanism of drugs, more than 4. And how do you decide on how you combine this? Are you able to sort of look a little bit at the molecular markers to try to drive the decision, or MRD status at the time of first response? Or
so now that we do have some agents that are targeting specific mutations, we are biopsying at every relapse. So I think it's very important to do bone marrow aspiration and biopsy at every relapse. And also, extramedullary disease is a rare, very difficult to treat phenomenon. And what we are doing is we're doing tumor-directed biopsies so that we can check for mutations, because the response rate of venetoclax with bortezomib and dex and T1114 and BCL2 upregulate by PCR is close to 100%, even in heavily pretreated patients. So it's important to check these mutations with every relapse, because we're going to have more and more options.
Are you able to do some NGS on the peripheral blood, or just you have to do targeted biopsy?
Not yet on the peripheral blood. We're not getting enough plasma cell burden.
Thank you.
Yeah. So if there aren't any other questions, I guess I will ask just one more question about infections with the bispecific T-cell engagers, because we're seeing many more, grade 3 and 4 infections. 30% in one trial, 25% in another trial. And when we combine it with daratumumab, we're going to start to see prolonged infections.
What type of infection you're getting?
Viral reactivation, parvo, we're seeing rare infections that are related to lack of CD4 T cells, and we're seeing increased COVID persistence. So, I think, how would you handle this in the setting of COVID? Would be my question.
Yeah, so far I think I agree, but even with daratumumab based combinations outside of the ones which are currently being looked at with the bispecific, we see a profound degree of immune suppression, and that includes bronchial infections, pneumonias, upper respiratory infections, and all of our patients have a very hard time overcoming it. One of the strategies that we use in order to prevent infections or reduce the severity is to give IVIG every month, particularly in the winter months. So I think that is something we could potentially consider in our patients who down the road, if and when this combination of daratumumab with other BiTEs is approved. And one can consider prophylactic antibiotics. I personally haven't implemented that into my clinical practice, except for patients who receive venetoclax-based therapy. I have been putting them on antibiotic prophylaxis, given the data from the Bellini study. But I think time will tell how results pan out in terms of infections with the BiTEs and monoclonal antibody-based combinations. Another concern is that as our myeloma patients continue to do well in the long-term setting, surviving decades or longer, with such profound degree of immune suppression, there is always a risk for secondary malignancies. So that is something I think we need to look out for as well.
I have a question a bit in that setting, is that patient myeloma live much longer. It's amazing, right? And they live well, relatively well for a long time. And but you see some patient that maybe you see more plasma cell leukemia or patient with CNS involvement. How do you treat those patients that have this very aggressive evolution?
I think this is really the high unmet need in our patients. And these are the patients who, despite all our therapies, they don't do well because you don't have time to bridge them to CAR T. They don't qualify for clinical trials because their disease is just relapsing out of control. Really, you just throw the kitchen sink, whatever alkylating agents tend to work a little better for the plasma cell leukemics. Certainly transplant, I would transplant these patients right away. That's one of the few things that's shown improvement in PFS and OS.
As a debulking?
As a debulking, yeah. Some of them you have to kind of do a 96-hour infusional type chemo with a harvest and then a transplant. But these are the patients we struggle with for sure.
And these patients respond to CAR T?
It's
they usually can get it.
Can get it because by the time you bridge them, they're sick, and if they respond, it's usually short term.
I think that is one of the disadvantages with the CAR T. It's the wait time, because during that wait time, we lose that opportunity to provide this very effective therapy. And I think this is where BiTEs will become very important.
Where do you see the field evolving of clearly treating myeloma earlier, more and more, smoldering and even before? Where do you see this is heading?
I mean, the trials that we've had so far for the high-risk smoldering have been very disappointing. The one that was most recently published, there were only 24 patients who were in the high-risk category, meaning that those were the patients that had an 80% risk of progression at 2 years, 24 patients, and those were the only ones to benefit. And the problem is, how are you defining benefit? You're not curing these patients by treating them with a single agent or a doublet. You're delaying progression and you're delaying end organ symptoms and potentially undertreating all of them. And these are patients that you can only if you monitor them much more carefully every month, every 6 weeks, you can find an end organ symptom before it occurs. So until we have potential curative upfront regimen, I don't see us treating smoldering or even high-risk smoldering myeloma.
That's interesting. Last question: you guys have a lot of experience in epigenetic therapy in myeloma, or adding to with epigenetic therapy. Can you comment on where I know you have some studies ongoing and all that?
Yeah, I mean, we had a lot of experience with panobinostat and vorinostat, and we found it synergized very nicely with IMiDs, with proteasome inhibitor, and we were able to restore response in heavily refractory patients. Unfortunately, due to some cardiac events and GI toxicity, and dosing irregularities, these drugs were not pursued further. But I think there is a role, particularly with checkpoint inhibitors and HDAC inhibitors in patients with myeloma, maybe at an earlier line of therapy, when you have a more robust T cell population. Because remember, as we go from line to line of therapy, we're losing T cells, we're losing NK cells.
Do you think the same rationale will apply for bispecific?
Yeah, I think maybe we'll see much less infection because the biggest, they're very effective. I think the biggest problem with these drugs is that you're getting sick patients and you're getting patients with infections and delaying therapies. So if we do it earlier, yeah, maybe better.
What is the impact of the functional imaging and PET scan on myeloma? Now, how obviously you do this at baseline, and how do you evaluate it in a response in addition to MRD?
Yeah, so PET-CT really detects only about 70-75% of myeloma-related disease in the bones. Many lytic lesions are not detected on PET and are not FDG avid. And so it depends on what your purpose is. If you're looking for If you're diagnosing a patient, for example, a smoldering patient that's high risk, and you're not sure if they have bony lesions, the PET-CT is not the best test. The better test would be the marrow MRI survey, because then you're going to detect closer to 90% of early marrow-occupying myeloma lesions. So you have a much higher sensitivity. In the relapse setting, or if you're looking for MRD and response, then I would say maybe PET-CT is better, because MRD negativity can be not very reliable because the bone marrow is patchy, you may not have a good sample. And so there are many cases where you have PET-avid disease and marrow negativity, MRD negativity. So you always want to check a PET to make sure there isn't any active disease before you declare a patient MRD negative. And PET-CT also helps determine response because you can measure avidity with each relapse.
So you mentioned 75%, detect 75% of the lytic lesion and the bone disease at baseline. That means 25% lesions are not FDG avid in a patient, or some patients are not FDG avid.
Some patients are not FDG avid.
Okay.
Some patients do not have FDG avid lytic disease.
Okay. There's a criteria in the prognostic and stratification. There's a criteria that is at least more than one lesion this morning that was presented. Most patients have more than one lesion, all patients.
Yeah, so for slim crab, in order to, if you have a patient who doesn't meet crab criteria, doesn't have lytic lesions, but has 2 marrow occupying MRI lesions, you can justify treatment, and I would treat those patients.
Okay, I got it. Thank you.
Yep.
Great overview on myeloma relapse. A lot of options. More to come down the road. Thanks for all the great work, both of you.
Thank you.
Thank you. We have now a 10 minutes break where we're going to also encourage you to visit the booth, and then we'll go into the session on CLL with Dr. O'Brien. Thank you very much.
Ladies and gentlemen, please join us at the virtual booth exploration. If you haven't joined the virtual booth yet, please head over to the sponsors tab under the expo on the event homepage. You will see the companies who we're sponsoring. To meet with a representative, select the company you would like to learn more about from the list. On the right-hand side of the booth, you will see which booth staff are available to meet. Click the Meet Now button to meet with a representative. Ladies and gentlemen, welcome back. Please welcome back Dr. Gua.
Welcome back, everybody. And I am very excited about the next session. We are very fortunate that Dr. O'Brien is running this session, and we'll talk about frontline therapy in CLL. And Susan has had an enormous impact across all leukemias with all the years at MD Anderson and everywhere, but also particularly in CLL. And Dr. O'Brien is a professor at Professor of Medicine at Irvine Cancer Center in California and UC Irvine, and again, a world expert in CLL. So we're very fortunate to have your perspective, Susan. Thank you for joining us.
Happy to be here. I will go ahead and share my screen so that I can you see the slides, Andre?
Yes, we can.
Okay, perfect. I will go ahead and get started. I'm going to talk about the evolution of frontline therapy for CLL, which is kind of changing every day. It seems to be moving so quickly in terms of the options. So these are my disclosures. I want to start out talking about the long-term follow-up of RESONATE-2, because this is the trial that led to the first approval of a small molecule as frontline therapy for CLL, namely ibrutinib. And this was a randomized trial of ibrutinib versus chlorambucil, with the primary endpoint being progression-free survival. Crossover from the chlorambucil arm was allowed at progression. And this trial was just updated. We now have 7-year follow-up, although stay tuned because it's going to be updated again at ASCO. So very soon, another month or so. This is on the left is the long-term progression-free survival data. I don't think anybody will be surprised to see it's a lot better with ibrutinib. However, what I think is really impressive is that there is still not a median progression-free survival. So these remissions are incredibly durable with continuous therapy. And at 6.5 years, 61% of the patients are still in remission. If you look at the top right-hand curve, what that's showing you is the PFS by 11q status. We know that these people do significantly worse with chemo than non-11q, which you can see in the two blue curves. But if anything, they seem to be doing better than other patients with ibrutinib because the yellow curve is the 11q. And then the other very remarkable finding is on the bottom right, which is that there's no difference in outcome with ibrutinib by IGHV mutation status, whereas we know with any chemoimmunotherapy, that is one of the most important predictors of PFS. So people who have unmutated IGHV have significantly shorter remissions with chemoimmunotherapy, but no difference with ibrutinib. Now, the one thing that you don't see in a lot of frontline trials are patients with 17p or p53 deletion, not because they're excluded, but because they only make up a small percentage of frontline CLL, probably 5 to 7%, whereas it's a very common clonal evolution. So in a relapsed refractory population, it's often a very high percentage of patients. So this is the largest series that's ever been published, looking at patients with a TP53 abnormality. And that's because data was pooled from 4 frontline trials that had ibrutinib as one arm. Note here that more of the patients had a mutation than a deletion, which is actually a flip-flop from what we normally expect. But that's because in some of these trials, including the RESONATE-2, which I just showed you, patients with p53 17p deletions were excluded, but there were no exclusions on any of the trials for p53 mutation. Here is the data for these patients, PFS on the left, overall survival on the right. Note that the 4-year progression-free survival was 79%. This is pretty much exactly what it was for all comers in RESONATE-2. So at least with this high-risk population in the frontline setting with ibrutinib, they seem to be doing just as well as non-17p or p53 mutated patients, which is very encouraging. Now, of course, we have another BTK inhibitor that we can use in CLL. I'm not going to talk about zanubrutinib today because it's not yet approved for the treatment of CLL, although some of you may have used it for other diseases like mantle cell, et cetera. Acalabrutinib is approved to treat CLL. And what you're seeing on the left is some of the IC50s for either acala or ibrutinib for some of the kinases that are inhibited by ibrutinib. And the important point here is that for many of those kinases, you can see that the IC50 is much higher for acalabrutinib. Why is this relevant? Because we think that some, if not most, of the side effects with ibrutinib are actually due to inhibition of these other kinases as opposed to inhibition of BTK. So we would think that this might be a drug that might lessen the way of side effects, and I'll show you that. Here's the ELEVATE-TN study design. Here, patients were randomized to acala alone, acala with obinutuzumab up front for just 6 cycles, and in both acala arms, then acala was continued indefinitely, just like we do with ibrutinib. However, note that acalabrutinib is given BID as opposed to once a day with ibrutinib. And the control arm here was chlorambucil obinutuzumab. The primary endpoint was for progression-free survival, and crossover to single-agent acala from the chlorambucil arm was allowed. So this is the 4-year follow-up, which is the longest follow-up that we have with this frontline trial. It's very interesting. Again, not surprisingly, acala was significantly better than chlorambucil-based therapy in terms of the PFS. But what's interesting here is that the higher curve is acala and obinutuzumab. So with just 6 months of antibody, and then it stops, we still see an interesting difference in the PFS at 4 years in favor of the combination. And I will say, up until I saw this data, which is not that old, I had not been giving antibody with acalabrutinib, because if you draw kind of a lineup at 24 to 27 months there, you can see, and that was the first presentation of this trial where we had data. There wasn't much difference in the curves. In fact, they were just starting to separate. So, and they did not look significantly different. So it really, when this 4-year data came out, it was quite interesting. I think to me, somewhat unexpected, because we know adding ibrutinib, adding rituximab to frontline therapy doesn't make a difference, but it appears to be potentially different with a more potent antibody. And again, it's not a large number of patients, but if we look at the subset with 17p or p53, on the left there, you can see that the curves are overlapping. So those patients are doing just as well as the non-TP53 with acala-based therapy. And then, of course, we have a completely different option if we go away from the BTK inhibitors in terms of small molecules, which is venetoclax, the BCL2 inhibitor. And we now have 4-year follow-up also for the CLL14 trial. And this trial was a randomized trial for mostly older patients because it was based on having a high comorbidity score and or poor renal function. And the patients were randomized to chlorambucil obinutuzumab or venetoclax obinutuzumab. In both arms, the antibody was given for 6 cycles and then stopped. And in both arms, the chlorambucil or venetoclax was continued for 6 more cycles, so a total of 1 year, and then treatment was stopped in both arms. So of course, a marked contrast of this trial to the BTK inhibitor trials is that this therapy is not continuous. Everybody stopped after 1 year of treatment. We now have a median observation time a little bit over 4 years. And you can see that there's no median progression-free survival with Ven-G or venobinutuzumab versus about 3 years with chlorambucil, which is pretty good with chlorambucil, maybe because it was given for a whole year, whereas in many trials it's given for 6 months. Nevertheless, much better with Ven-G, 78% at 4 years. However, this is interesting. We noticed that in contrast to what I showed you with the BTK inhibitors, there is a big difference between p53 abnormal patients and non-p53 abnormal with Ven. So those 2 blue curves are the Ven curves. Now this isn't bad. You see that there is a median now reached in the p53 abnormal patients at about 4 years. That's not bad if you consider that this is 3 years off therapy. So they've actually been off treatment 3 years. But given what I showed you for ibrutinib, where at 4 years, the PFS was 78% in this population with continuous therapy. This is the one population where I would not choose venobinutuzumab to treat them. Now, interestingly, also in contrast with the BTKI, we also see a difference with Ven-G between mutated and unmutated. But here, both groups are doing really pretty well. You see that in the unmutated, the lower blue curve, the median progression-free survival is about 5 years, not quite. Well, yes. So, and remember, again, that's 4 years off therapy. If you've been off therapy 4 or 5 years, I'd say there's a very good chance that you could retreat these patients with Ven again, and so not even necessarily have to change therapy. So in the unmutated group, I think you could make a good case for either category of drugs. But again, the PFS per se is not as long as in the unmutated, because with ibrutinib, remember at 6.5 years, there's still no median progression-free survival and no difference in overall survival yet. So we have some different options here. Some of the things to consider are with the BTKI, they're obviously convenient, no infusions. Of course, I did make the comment now about potentially adding obinutuzumab to acala, but no intensive tumor lysis monitoring. There's very long-term efficacy. I told you the ibrutinib 8-year frontline data is going to be presented at ASCO this year. Ibrutinib is the only drug that's been compared to FCR or BR in the frontline setting. So better chemoimmunotherapy, if you will. And there is more data for the efficacy event after ibrutinib progression, although we are getting more and more data for the reverse. Time goes on. Obviously, a big advantage of Ven-G is the potential for time-limited therapy. No known cardiac or bleeding risks, unlike with the BTK inhibitors. Less concern for long-term adherence, as the patients don't have to take the drugs for 4 or 5 years, et cetera. And obvious potential for cost savings. Now, there also is data that has been presented, although this is not an approved regimen, but it likely will be soon, and I'll explain that to you. There's also very interesting data now for combining small molecules. So the first group that actually published on this, and the only group that has a published publication so far, is MD Anderson, but they update their data each year at ASH. So we're getting some nice long-term follow-up in addition to their original publication. So this is the schema. And in all these small molecule combinations, this is what you're going to see, some kind of lead-in with whatever the BTK inhibitor is. In this case, it's ibrutinib. And then initiation of venetoclax ramp up. At this, in this trial, it's after 3 months. Why are all these trials designed like this? The idea is that you can debulk the patient with the lead-in. And in some trials, which I'm not going to talk about today, there's also antibody given. So you can see a lead-in with the BTK inhibitor, or in some trials, it's a PI3K inhibitor, an antibody, and then starting venetoclax later. And this has been shown to markedly reduce the tumor burden at the time that ven starts and lower the risk for tumor lysis. Now, in contrast to what I'm going to show you in a couple of the other trials, in the MD Anderson trial, it's not fixed duration treatment in terms of a fixed time. Patients can stop therapy if they become MRD undetectable, but otherwise in this trial, they can keep going. So this is the data they presented most recently at ASH in December. And you can see that about in the green, 72% of patients become MRD undetectable. And this is using 10 to the fourth as the standard in the bone marrow. So a very high percentage of patients becoming MRD undetectable and also stopping therapy in that case. And this is the progression-free survival curve with about a median of 4 years of follow-up, probably the best progression-free survival curve I've ever seen in the frontline setting. Really, really impressive remissions. So where are we heading? And I'm going to show you a little bit of this data. The only point I want to make about these trials that are all in progress is that every single one of them has a small molecule combination. So that's clearly where the field is going. Now we do have some updates on three of these trials from ASH. The first is the Captivate trial. So this is also a 3-month lead-in with ibrutinib followed by 12 cycles of the combo. So the first 12 months is exactly the same as MD Anderson. Note they have MRD cohort and an FD cohort, which is fixed duration where everybody stops after 15 months. In the MRD cohort, as you can see on the right, depending on their response at the end of 1 year of the combo, they're randomized if they're MRD undetectable to placebo or ibrutinib, if their MRD is detectable to ibrutinib alone or ibrutinib and venetoclax. Now, we had an original presentation at 1 year, but now we have longer follow-up, and this is in the randomized cohort. Note that confirmed MRD undetectability was a little bit lower at 58%. The overall was 74%, but for confirmed, you had to have 2 values more than 3 months apart in both the blood and the bone marrow, which is why that drops down a bit to 58%. Still a high number. Note the randomization, but now 43 to placebo, 43 to ibrutinib. In the MRD undetectability, not confirmed, 31 on ibrutinib, 32 on ibrutinib venetoclax. So not big numbers when we get into the subsets now. Here's something quite interesting. Look in the 2 columns under confirmed UMRD, so undetectable. Again, the randomization was placebo to ibrutinib, and the high-risk features are evenly distributed. But here's something quite interesting. Note that in both of those randomized arms, 70% of the patients are unmutated. Okay, they're undetectable MRD. Now let's look at the 2 right-hand columns. These are people that were not that did have MRD detectable. Note that in both randomizations, the unmutated were 45 to 47%. What is this saying? It's saying the unmutated seem to have a higher likelihood with this combination of becoming MRD undetectable. Very interesting. We don't have an explanation for that with either small molecule. Ibrutinib is the same. Then G, I showed you they have a quicker progression-free survival, but they seem to be doing better. Now I might chalk this up to fluke, but I'm going to show you this is true in another trial in a minute. So it seems to be real. So here's the PFS curves at 3 years. Note there was the patients that were confirmed MRD undetectable. There was no difference between ibrutinib and placebo. And in the MRD detectable, note the progression-free survival are fabulous with either continuation of ibrutinib or ibrutinib venetoclax. Now, The trial that will actually lead to a approval of ibrutinib and venetoclax is the GLOW trial. And this is a registration trial because it's a randomized trial, and I'll show you that data. So this is a randomization to ibrutinib and venetoclax. Same cycle, same scheme I showed you. 3-month lead-in, 12 cycles of both, but in this trial, everybody stops therapy or chlorambucil or obinutuzumab. So this is finite therapy, 1 year. This is the progression-free survival curves. Progression-free survival looks excellent with about 3 years of follow-up, obviously much better with the combination. If we look at the MRD undetectability rates, we see it's much higher for ibrutinib ven than chlorambucil, not surprisingly. And with ibrutinib and ven, and we see this pretty consistently in all the trials, the rates in bone marrow and blood are very, very similar. Going forward, we can probably drop having to do bone marrows to assess MRD in patients. Note the rate was in the 50s here. Now, here's exactly what I showed you in the Captivate trial. On the left 2 bar graphs, those are unmutated patients. The right 2 bar graphs are mutated patients. And we're looking at the MRD in blood or bone marrow. And what you can see is that the bar graphs on the left are higher for either bone marrow or blood. And again, this is the second trial showing higher rates of MRD undetectability with this combination in unmutated patients, which is again quite interesting. And then the last trial I want to mention today was just presented at ASH for the first time. So this is the first time we saw any data from this trial. And this is a bigger, somewhat more complicated trial. Note that there's 4 arms in this trial. There's a chemoimmunotherapy arm, which is FCR or BR, and that's assigned based on age if the patient's randomized to chemo. Then there's R-Ven, rituximab ven. That's not the same schema as in the relapse Murano trial, and I'll show you that. Then there's G-Ven, so obinutuzumab ven, and then GIV, which is ibrutinib, venetoclax, and obinutuzumab. And the co-primary endpoint is the MRD undetectability at 15 months, as well as PFS. All of these regimens are fixed duration except the last one. Let's just go through them. FCR-BR is obviously 6 months and stop. RVE is now given exactly like GVE, so not in the Murano trial. The antibodies given first for a few doses, then the ven ramp up, then ven is continued for 1 year. So the only difference here between RVE and GVE is the antibody. Otherwise, the regimens are exactly the same. So this is really a comparison of R and G head to head. GIV is the only regimen where the patient can continue past a year on therapy, because if they're not MRD undetectable, there is an ability to continue single agent ibrutinib for up to 3 years, but stopping at some point along 3 years if they become MRD undetectable. So let's look at the co-primary endpoint here of MRD undetectability at month 15, or after 1 year of the combo regimens, or 6 months of chemo. The first bar is the chemoimmunotherapy, 52% MRD undetectability, 57% with RVE. With GVE, it's up to 86.5%. And with the 3-drug regimen, it's somewhat higher at 92%. Note that this is between chemo and ven-G, statistically significant. Between chemo and GIV, statistically significant. Between chemo and RVE, not significant. So this is quite interesting because it really points out the potency of obinutuzumab as an antibody, because again, the only difference between RVE and GVE is the antibody. So to conclude my talk, ibrutinib long-term follow-up as frontline therapy shows incredibly durable remissions, 61% PFS at 6.5 years. And again, stay tuned for the 8-year follow-up at ASCO. Ibrutinib is the only agent with longer PFS than every single chemo we have. Acalabrutinib plus or minus G results in very durable remissions also, and appears to be somewhat better with G. Then G has a very similar PFS rate at 4 years. But remember, that's fixed duration therapy, so everybody's off treatment after 1 year. I would say patients with a P53 abnormality do better with a BTKI. Now, is that because a BTKI is a better drug for them? Or is it simply that finite therapy is not a good idea in those patients? Don't really have a way to answer that question since we don't have continuous Ven therapy to look at. But nevertheless, with the way the regimens are now, I would certainly favor a BTKI. And then combinations of small molecules look really promising. The obvious question is, are they going to be better than sequencing? I mean, if we're going to be out to 8 years and maybe don't have a PFS for ibrutinib, and we know we can get very long remissions switching later to Ven, it's kind of an obvious question, but I think that's the way the field is going. Why? Because the reality is what we would like to do in the long run is cure patients. Now, I'm not saying MRD undetectability is synonymous with cure, but I think it's the first step in trying to find a cure for patients with CLL. So I'll stop there and thank you for your attention.
This was a great overview. A few questions, Susan. So the first question that comes all the time in those talks now is that, are there patients now that do still use chemoimmunotherapy, i.e. FCR, because VR is not that great in that setting? And,
sorry. So you're right. If I was going to use chemoimmunotherapy, we're only talking FCR because, and I am one of those people who believe there is a cure fraction. I personally have patients that are out 20 years, still in remission after FCR. However, truthfully, I think COVID put the final nail in that coffin because nobody was going to start giving people chemoimmunotherapy during COVID. Had I given it up until COVID or given it to the patient as an option and actually had people elect to take it? Yes, because there are people who really liked the idea of a finite therapy. I will say that was mostly in the days before Ven-G. So the choices were continuous BTKI or short, 6 months of chemo. I think now with Ven-G as an option, that's kind of another nail in the coffin because that's not the only way to give finite therapy. So I think chemo is definitely being buried deeper and deeper.
Thank you. Question on the, we'll go back to COVID and CLL later, but I wanted to talk about the ibrutinib venetoclax trials. The unmutated patients is very, very impressive, as you mentioned. But the P53 patients, you would expect that they do better because with ibrutinib they do great. Venetoclax maybe not as much, but you would expect that they would do better than they did here, or this was small numbers.
So we haven't really seen in the ibrutinib venetoclax combo data, we haven't seen the breakout for 17p, but my guess is those numbers are quite small.
Yeah. And then the question, the trial was really interesting. The trial, the question of the antibody that always came, question of G versus rituximab, and clearly that trial really answered this because it had the same schedule and then it was very helpful. But if you look at the GVE versus the GIV, the ibrutinib didn't add much.
Right. So if they didn't say whether that was significantly different, I suspect it's not. The numbers were very close there. I guess the real question would be, since the patients are able to continue ibrutinib and they're not all stopping in the GIV arm, will you have conversion, more patients converting as opposed to the fixed duration therapy? And as time goes on, longer PFS. Note that I did not show you any PFS data, and it's not because I was hiding it. They haven't shown the PFS data yet. So we actually haven't seen that. I'm guessing it may be updated at ASCO or EHA this year, but they did not show PFS curves. They didn't have enough events to show the PFS curves at ASH.
I hope I remember well, but in the first presentation of the Acala obinutuzumab versus Acala versus Chlorambucil, there was no difference, but although there was maybe a higher MRD negative in the combination with the anti-CD20, and the long-term follow-up shows that there was a benefit of adding the obinutuzumab. But this was just for Acala because in the ibrutinib, the only data we'll have was rituximab. We didn't have any data on ibrutinib and Gazyva.
So there is, but there's no control on. So there were two trials that looked at ibrutinib rituximab versus ibrutinib. Yeah. One was the big intergroup trial of BR versus I versus IR. And that trial clearly showed I and IR where the antibody was given for 6 months, where the PFS curves were identical. MD Anderson also did a trial in relapse where it was just I versus IR, not a frontline trial. identical PFS curves. So there's 2 randomized trials that show that. In the Illuminate trial, the Illuminate trial was ibrutinib obinutuzumab, but versus chlorambucil obinutuzumab.
Yeah.
And obviously it was better than chlorambucil-based therapy, but there was no third arm of ibrutinib alone. So there is data for ibrutinib obinutuzumab, and it actually is FDA approved on the basis of that trial. I don't think anybody ever uses it. I certainly don't use it, but that's because I think I was also very swayed by the ibrutinib rituximab negative trials, whereas it's very clear obinutuzumab is a completely different antibody, but there's no control arm.
We can make the assumption that the BTK are equivalent, particularly when it comes to ITK inhibition and all that with ibrutinib versus Acala, but the long-term follow-up would suggest that the anti-CD20 would help the long-term outcome.
I think that's a true statement. But again, before the 4-year follow-up on the Elevate-TN trial, that Acala frontline trial, we didn't really have data to suggest that. So that data is really, I think it's pretty strong, but it's just emerging.
Mm-hmm. And when you see someone who has relapsed has progressed after on ibrutinib, and there's a whole work that you participated in, and also with Anthony Meadow that's looked at the sequence, what do you use? Or do you repeat a BTK? Do you use a PI3K? Now we have venetoclax to complicate the picture a little bit. So can you give us, our audience, a little bit, if you see someone who has relapsed, who has been exposed to BTK inhibitor, and then now what do you give them?
Well, I think the non-covalent inhibitors are really exciting. There's 2 of them in development, the nemtabrutinib and the pirtobrutinib. The data looks great, but neither are actually yet FDA approved.
Mm-hmm.
If they were, so right now I would go to ven-based therapy. I actually tried and use ven-obinutuzumab in relapse, not ven-R. I have been able to do that in terms of insurance approval because I think we've just talked about how much more potent obinutuzumab is. If one of those non-covalent inhibitors was available, my choice would be probably to exhaust the MOA, if you will. I most likely would change to a non-covalent inhibitor before I would go to a venetoclax-based therapy. But right now, without, or obviously put the patient on a clinical trial. But we're waiting for the non-covalent inhibitors to be approved.
So if someone is not p53 mutated, and by the way, the p53 mutation, obviously, people look at deletion 17p, as you mentioned, in CLL, it's easy, but there's also by NGS more abnormalities. So do we have more data now that we have better ways to look at the p53 pathway abnormalities than just the deletion 17p?
Yeah, I think unfortunately FISH is easy. People are used to ordering it, but people are not looking for p53 mutations. Now they generally do occur with 17p deletions, but not always. And so it really is very important to get p53 mutation status on patients. And nowadays, all the big commercial labs offer it. So you just have to remember to order it. It's not really that hard.
Mm-hmm. So if you see someone who doesn't have p53 abnormalities, and who is quote unquote younger, doesn't want to get chemotherapy, are you going to use a venetoclax G-based therapy frontline because it's a finite and then you get a very deep response and you can stop, or you're going to continue on the BTK sort of a strategy?
I would prefer obviously you have to discuss the options with the patient. Sure. It comes down to, but I would prefer a BTK inhibitor.
Okay. And in the now the patient who have we see maybe less of those. There was some question at the beginning that patient who had BTK exposure become Richter-like, even if they are not Richter transformation morphologically speaking. So it may be more aggressive course. I think that was mostly in the relapse refractory setting, correct?
Yes.
And when you see
I'm shutting off my video for 1 second because I'm moving because I don't have a power cord and my computer's about to die, but keep talking.
We'll wait a second.
Okay, I'm back.
We are glad you're back. So what would you do in this patient, the rare patient that transform, that have Richter now?
Oh, Lord. You know, when I'm teaching fellows, I always say Richter's is like the blast crisis of CML. We don't see it as much anymore, but it's just horrible when it happens. We don't really have good therapy. You know, we still treat them like de novo large cell lymphoma, even though they have much poorer responses. The idea would be to try and get them to allo, which is very hard for a number of reasons. Number one, they often have a lot of B symptoms, and so they start with a poor performance status. If they do respond to chemo, it tends to be transient, and a lot of them are just old and infirm, and you can't take them to transplant. That would be the end goal. There is some data for the checkpoint inhibitors that was first published a couple of years ago by Mayo. MD Anderson has some very interesting data combining ibrutinib, even in ibrutinib refractory patients, with nivolumab that they're about to publish. But outside of, you know, I would look for a clinical trial. I mean, I think all these people are candidates for clinical trials. Unfortunately, there's not a lot of them. There's not a lot of companies that are interested in developing drugs in Richter's. But it's really still a very dismal prognosis, unfortunately.
So now that we have ibrutinib, you have to treat, or BTK in general, for a long time until progression. But now you have combination of treatment that you could potentially do a finite treatment, as we discussed. The field in oncology, we talked about myeloma this morning, is evolving to maybe to treat earlier, smoldering. I'm not saying we're going to do this in CLL, but is the field going to involve also, you know, this whole group of patients that are diagnosed, are quote unquote not symptomatic, not cytopenic, and they keep being monitored and not just watch and wait, but wait and worry. And would these treatment options be possible to bring them earlier, because you can stop potentially the natural evolution of disease?
Yeah, so there are a couple of trials actually looking at this. There's one the Germans are doing where they're randomizing high risk, medium to high risk, and this is using a German, kind of like the IPI, but not exactly. It's a German risk score, and they randomizing them to ibrutinib or placebo. The SWOG trial, which is an intergroup trial here in the US, is looking by IPI and only takes high risk and very high risk. So it's a much higher risk group, but because that's a smaller denominator, the trial's going to be going on for a while. But it's a randomization to upfront therapy versus later therapy. And the nice thing to put in a plug for that trial, and basically if a patient has a 17p deletion, almost all of them are eligible based on that alone, is that all of the drugs are free, and if the patients get randomized to later treatment with acalabrutinib or obinutuzumab, they get if they don't get it for 3 years or 4 years or whatever, they still get free drug. So it's a really nice trial. It's not that easy to accrue because this is a small population, but I would encourage people to look out for that trial because it's trying to answer a really, really important question.
But if you devil's advocate here, if you use venetoclax-based therapy, potentially in those patients, you could stop therapy and potentially, quote unquote, stop the evolution of this disease. Because BTK, you have to continue to treat them again.
Yes, yes.
This is not being addressed as we speak.
No.
Yeah. And one thing that now we should talk a little bit about COVID and CLL and COVID in general. So obviously this is a concern because patients on active therapy, there is the data that suggests if you have BTK, you're somewhat protected from an immunological storm, right? But you're still immunocompromised by the underlying disease. So how do you handle those patients, and how did COVID change the management of your treatment of your patients?
No, I think when COVID first started, one thing many of us did was try, if people were, sort of at the point where you would have started therapy, we tried to delay, no matter what the therapy was going to be. And after a while, it became clear that COVID wasn't going away. And I mean, you can only delay for so long. So I think it did affect management at the beginning. I don't think it does much anymore. I think what has been a godsend for CLL patients, and I realize not everybody's been able to get it, is Evusheld. Because there is plenty of data that people, even not getting any treatment, although they do a little bit better in responding to the vaccine, they still do quite poorly in responding to the vaccine. So now we are actually able to give people antibodies to protect them that lasts for 6 months. So I think it's sort of like a miraculous gift. And I think every CLL patient that has the ability to get it, because I know in some places there's limited supplies, et cetera. I was just reading that there's more of a government push now to make it, along with some of the other drugs like Paxlovid, more widely available, which is a good thing. But I think every CLL patient should be getting Evusheld.
Yeah, I agree. And there has been less anti-CD20 usage probably during the COVID.
I think for sure there was in the beginning. Again, whether that's impacting now, you know, are people not using Ven-G 2 years into it? I don't think so. I think for sure in the beginning, but now I think it's less. And also, to be fair, the other difference between now and then, other than 2 years elapsing, is we have therapies, we have vaccines, you know, we have treatments. So it's a whole different, it's so much different now than 2 years ago.
So the landscape has globally dramatically changed, but we still get this subset of patient that sort of goes from one failure to the other relatively quickly. And that's one of the reasons maybe to not start treating also too early, because we don't know how we can get by how much mileage. But what's your take on the cell therapy and CAR-T? Because these p53 patients that relapsed early, we used to do allo transplant for those patients.
Yeah. I think the CARs promising. You know, there is the interesting data of using ibrutinib with the CARs to affect the microenvironment. That data is quite limited. I think it looks interesting. I wouldn't say it's a home run at this point. You know, just like I was talking today about how quickly the field is evolving in CLL, I don't think the CAR-T field is very static either. So what I'm getting at is I think the CAR-Ts that we have now are not the same ones necessarily in CLL, where it's all investigational because there's no commercially available CAR. The investigational CARs are changing and they're becoming more effective. So I think it's here to stay. I don't know exactly what the registration pathway is for CLL. Can't speak to that, but I think we'll see a CAR for CLL.
Mm-hmm. And there's some data, it was from MD Anderson phase 2 that had quite a bit of CLL patient with NK cells.
Yes. Oh, sorry, I didn't even mention that data. Yes, that's also very impressive data. And there are commercial ones being developed right now that look very promising. Yes, yes, you're absolutely right. That came out of MD Anderson and that data looks fabulous.
Very good. Thank you very, very much. As always, amazing coverage of CLL. You've done so much for the field. And thank you for joining us this morning.
Happy to join.
Thank you. I want to thank you all for having attended this session, first half day on blood cancer review. And this is, as you know, you could see this morning that this is, the field is really exploding. The lesson we can learn from this is that it's important to attend those sessions because we get to hear from experts where the field is going and what matters, because there's so much innovation. The second lesson is that we need to participate in clinical trials. And the third lesson is that I would say that we need to also work together on real world data to really understand better the sequence of care. At the end of the day, every patient, there's two questions in oncology, more and more pressing. Every patient wants to know what's my best option now. And as a society, we want to know what's the best sequence of care to optimize resource, et cetera, et cetera. So this was a really very helpful session, very intense and covered a lot. And I hope you appreciate it. And I want to wish you all a great weekend. I want to thank Colin Burke and the team and Mike for setting this up. So thank our sponsors. And that I hope you had the time to interact during the breaks we had this morning. And I'm very much looking forward to the next session next week, where we're going to wrap up with a bit more focus on other lymphomas and cell therapy, CAR T cells and NK cells. Have a great weekend and see you soon. Thank you.
Once again, ladies and gentlemen, thank you for joining us. If you look at the screen, you'll see how to obtain your CME credit. There will be a feedback survey on both the event dashboard page and in your email. Once you take the survey, you will receive your certificate. If you have not received your certificate by 5 p.m., please contact JTCC Events at hmhn.org. Once again, we hope you enjoyed today's presentations and enjoy the rest of your day.
Thank you all.